Good morning, everyone. So we are going to start our session. I welcome you all to the IRC RCOG pre-summit workshop on clinical safety in healthcare professionals. Before we start the session, we will start our session with the recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر.
Jazakallah. Today's session is designed to provide valuable insights and practical tools to enhance our shared mission of improving women's health. It is my honor to introduce our guest of honor, Rani Thakur and Kate Lancaster. Rani Thakur is the president of RCOG, the third woman president, the first woman of color. She became the RCOG president in 2022. She is a consultant obstetrician and urogynecologist in Croydon University Hospital and honorary senior lecturer at St. George Hospital, London. She has over 200 publications and has made significant contribution to improve perineal trauma outcomes by training midwives and obstetricians to improve the safer maternity care worldwide. Thank you very much for joining us today. Our second honored guest is Kate Lancaster. Kate has joined the Royal College of Obstetricians and Gynecologists as Chief Executive in 2019. She has previously held a number of board director roles in UK National Health Services. She has invested in building successful international partnership for the benefit of women's health worldwide. We are delighted to have you both today with us. As we begin this exciting journey, it is my privilege to introduce the key host who made this event possible. Professor Nazli Hamid is a respected figure in the field of obstetrician and gynecologist. She is current chair IRC RCOG Pakistan and chair maternal and child health Shalimar Hospital. She is director of Urogynecology Fellowship Program. She is the one who was instrumental in establishing subspecialty of urogynecology in Punjab. And she is also the one who brought MRCOG Part 3 examination to Pakistan. Her leadership continues to inspire and guide us towards meaningful progress. I welcome Dr. Nazli Hamid to come forward on the stage for an opening note and formally welcome all the guests.
Dr. Shima, thank you very much for a very thoughtful introduction. Ladies and gentlemen, it's my great honor to welcome you all to the pre-conference workshop of the second Shalimar IRC RCOG Summit. I extend a very warm welcome to our distinguished guests, none other than the senior most leadership of the Royal College of Obstetricians and Gynecologists, the President, Rani Thakur, and the Chief Executive Officer, Kate Lancaster. Thank you so much for your first visit during this tenure to Pakistan. I also welcome Dr. Wasim Lodi, the Liaison Group Chair, who is here with us for the third time and has been with me throughout the teething phase of my journey as an IRC Chair from Pakistan. I am very delighted to welcome his team members, Dr. Sherzad Ruabi and Dr. Wayung, and we are thankful to them for their second visit to Pakistan. Last year also they conducted a workshop on human factors and PPH. Dear delegates, as you all know that our journey with the RCOG over the last couple of years has taken significant milestones in shaping the future of women healthcare in Pakistan. The initiatives we have taken together are not just about immediate successes. They are about laying the foundation for a sustainable, long-term improvement in the care and well-being of women across our nation, and enabling our youngsters a journey which has been the most fulfilling journey of my life. The presence of the senior-most leadership of the RCOG here today highlights the strength of Pakistan IRC partnership with the Royal College. While their formal talks are scheduled for tomorrow, I shall call both of them shortly to say a few greeting lines to brighten up this morning. I am ever so grateful to both of them for lending their voices, esteemed voices, for this important event. Our workshops today will focus on human factors in clinical practice and the postpartum hemorrhage management. They are designed to provide valuable insights to the healthcare professional and enhance their clinical skills. Additionally, I am very grateful to the President RCOG, Rani Thakur, who has consented to inaugurate the Urogynecology Clinic at the Shalimar Hospital in the heart of our Women Health Center, a comprehensive facility representing a significant leap forward in women health services in Pakistan. I think this is a dream come true for me that my urogynecology center be inaugurated by one of the most well-renowned urogynecologists in the world. Thank you so much, Rani, for that. The main summit, running from January 14 to 16, will be inaugurated tomorrow and will delve into the theme of moving towards subspecialty development in Pakistan. On behalf of Organizing Committee of the Second Shalimar IRC RCOG Summit, I extend a warm welcome to all the delegates and participants. Your active involvement and contribution will make this summit a platform for innovation, learning, and progress. Thank you.
Thank you, Dr. Nazli, for your warm and inspiring welcome, and we truly appreciate your leadership and vision. So before we proceed to the next presentation, I would like to welcome Professor Zahid Bashir, the Principal, Shalimar Medical and Dental College, and Dr. Aisha Noman, the Chief Operating Officer, Shalimar Hospital, for joining us today. Thank you very much. So our next speaker is Dr. Scheherazade Rouabi. She is consultant obstetrician and gynecologist from North Middlesex University Hospital, London. She has a special interest in acute gynecology, early pregnancy complications, and medical acupuncture. She has developed skills in office procedures and is the lead for outpatient surgical management of miscarriages. She also leads the award-winning female genital mutilation service for hospital and performs de-infibulation as an outpatient procedure. I now invite Dr. Scheherazade to kindly come up to the stage to deliver a presentation on understanding situational awareness.
Assalamu alaikum, everyone. Good morning. Thank you for inviting me to this meeting. We're going to spend the next 15, 20 minutes talking about situational awareness. We know that maintaining situational awareness can improve patient safety. So we're going to talk about the principles of situational awareness. Sorry, I just need to... And then we will be talking about factors that can reduce some situational awareness, and then we'll discuss how to increase and maintain our situational awareness. So, what is situational awareness? Basically, is having what we call a helicopter view. It's knowing what's happening around us, and maintaining the situational awareness, as I said earlier, plays a big role in providing safe service. We're going to watch a video next, and I want you to watch carefully, and then we're going to identify a few points here. Okay, can we play the video, please?
Somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
Why, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
But how did you know?
Madam, as any horticulturist will tell you, one does not plant petunias until May is out. Take her away.
That's right, madam.
It's just a matter of observation. The real question is, how observant were you?
Action.
Clearly, somebody in this room murdered Lord Smythe, who, at precisely 3:34 this afternoon, was brutally bludgeoned to death with a blunt instrument. I want each of you to tell me your whereabouts at precisely the time that this dastardly deed took place.
I was polishing the brass in the master bedroom.
I was buttering his lordship's scones below stairs, sir.
Well, I was planting my petunias in the potting shed.
Constable, arrest Lady Smythe.
There were 21 things that changed in this video. How many have you spotted? Anyone has spotted 1? 2? Okay. So this is just to show that it's very important, or it's rather difficult to keep focused when there are a lot of things happening around us. If we look at the definition by Dr. Mika Ansley, who was a chief scientist in the US aviation. So you read it, I mean, when we read this definition, it's very difficult to remember it, but there are 3 components of situational awareness. One of them is perception. So this is when we say knowing what's happening around us. And then the second one is comprehension. It's understanding what's happening. And then the third one is projection, which means that you need to make plans. Once you understand what's happening around you, you need to project in the future what's going to happen and start making plans. So whenever you are faced in a situation and you are questioning your situational awareness, there are 3 questions, very important. If you can answer these questions and you move smoothly from one to the other, then you know that you are following what's happening. If you read, anyone familiar with Each Baby Counts? Probably people from Pakistan who are taking MRCOG exam, these are the papers that people read to answer all the questions, like Embrace Report, Each Baby Counts. So Each Baby Counts is a project by RCOG looking at all babies who had brain injury and look at individual cases and identify the cause of the bad outcome. And when looking at all the cases, like this is a 2015 report, looking at all cases, more than 50% of cases of brain injury were related to CTG misinterpretation. And CTG interpretation is always related to situational awareness. So there were a lot of talk about like people losing their situational awareness, like not knowing the key principle of perception, comprehension, and projection. Every year there is a report from Each Baby Count, and the latest one, they produced a report and the Learn and Support. This is with collaboration of the Royal College of Midwives. This is a very interesting and important piece of work. When we look at the latest report, they talk a lot about lack of escalation or delay in escalation, which was responsible for the bad outcome for the babies. And they developed this work to help healthcare professionals to develop their skills and to encourage them to escalate situations. So we go back to the definition of situational awareness, and we see here that they emphasize on identifying the problem, communicating the problem, and acting, and like finding solutions to the problem. So if we correctly recognize deviation from normality, so here we know what's happening. This is the first question that we are answering. What is happening? There is a problem, we understand the risk factors, and there is clearly deviation from protocols. So I'm understanding what's happening in this context. If I understand, I'm going to make I'm going to explain, like trying to understand why it's happening, the physiology behind it, or the reason behind it, and then I start communicating and trying to find solution. And again, in the latest report, there was failure to escalate, and that failure to escalate was as a result of either lack of awareness. So we see that losing situational awareness is always there when it comes to adverse event. So this is, I think everybody's familiar with a labor ward board. Quite busy board. And sometimes when we are on call, we try to maintain our situational awareness. So I'm going to ask in the audience, how do you maintain your situational awareness when you have a busy board and a busy shift? And you have a board like that, what do you do? Maybe you can hear it from Wasim Lodi.
I tend to go back to the board, so to look at what has changed, and then to have a better discussion with the team members to keep myself informed of what's happening.
So, okay. So how? Sorry, I can't hear. Sorry. So remaining present in the situation, yeah. You have somebody with preeclampsia, you have one awaiting cesarean, and then one for ECV, and then somebody bleeding in room 3. How are we going to maintain that situational awareness with all these things happening in labor ward? So communication is very important. So we're going to look at, the slide. Okay, I'm just going to skip this. I'm going to give you an example. This is a real case from our unit at North Middlesex Hospital. So we had a 32-year-old lady who was admitted to labor ward because she was diabetic, booked for elective section, and because she was before 39, she was 37 plus, and she needed her steroids prior to cesarean. So she was admitted to labor ward, just to have her 2 doses of steroids, monitoring, maybe sliding scale if her BMs go up. And then she will have her cesarean the next morning in the elective list that starts at 8:30. She was known to have atypical antibodies with high titer. In my unit, we have patients like that. They come just for steroids. So it's not that we are not interested in knowing what's going on, but they're there on the board, and in the handover, they will say, oh, she's here just for steroids. We don't need to do anything. Just by saying she's just here for steroids, as if we are losing interest in like reviewing what's going on and reviewing her background and everything. So what happened is that at 6 o'clock, it was time to repeat her CTG. And the CTG is what you can see on the screen. What do you think of the CTG? What is this? Is this a normal CTG? Sorry, can you say it louder? The baby is tachycardic. We know that at term, the baseline usually drops. It's not like when you have a preterm CTG where it's acceptable to have a baseline of 160, yes? Any other things, any other features? Look at the variability. It looks like a sinusoidal CTG, isn't it? Do you think it looks like a sinusoidal? Maybe you can't see it from far, but here, especially here. Okay, so if we say it's a sinusoidal CTG, what are we expecting? Usually it comes with anemia, yeah? And why this baby is subject to have anemia? So because the patient has high titer of atypical antibodies. So these details, they weren't discussed properly in handover, because all what the registrar could hear is, this patient is just here for steroids, and she's booked for section the next morning. When the CTG was reviewed at 6 o'clock in the morning, the plan was, this patient is going for cesarean anyway, but they didn't recognize the pathological pattern of this CTG. This mom had cesarean at around 8:30, 9 o'clock as planned, and the baby was born pale with hemoglobin of 45, like 4. If we look at this case, this is a clear illustration of losing situational awareness. People didn't know what was happening with this patient, because if they knew about the risk factors, they would have not planned, but they would have expected an outcome like that. So if they see the CTG with a sinusoidal trace, they would be thinking it could be anemia, but knowing that it could be anemia and this baby needs delivering is not enough. We need to plan ahead. We need to project in the future. If this baby is born anemic, the baby will need transfusions straight away. So all of this was missed just because people didn't have enough information, maybe lack of experience, lack of knowledge, not knowing, not recognizing that this CTG is pathological. All these factors contributed to not being fully aware of what's happening in that labor ward. Okay, so that case, we can say that it was 6 o'clock in the morning, in the middle of a night shift. Maybe the person was very tired to be able to analyze the CTG. High workload, yeah, it could be a reason, because that was the least of their worry, because this patient is booked for elective cesarean in the morning, so you can leave her alone, and then in the morning the elective team will come. Distraction usually affect our situational awareness, and the typical example is when we are operating. And especially registrars, if they are operating and then the midwife comes and asks them about the patient in room 3, and then we stop, we give them advice, and then we try to remember who is in room 3. So distraction can play a big role in losing that situational awareness. Lack of communication, clear example was our case from labor ward, and lack of experience as well. We've seen it before. We know what's going to happen. Let's just avoid the same mistake. So if you are experienced and you've seen it, if you had exposure to similar cases, sometimes it helps to maintain your situational awareness. And of course, execution of improper procedures, and this is the importance of sticking to protocols, guidelines, and SOPs, so standard operating procedures. If we lose situational awareness, then it's going to affect your team, it's going to affect your patient, and you start forgetting information. Even your communication will be affected. You're not going to give enough information, incomplete information, and you forget what you need to add to your information to be able to deal with the case. So how can we recover or maintain our situational awareness? Being vigilant, yes. Take time. Very important. Take time and ask all your questions. Don't rush. If you think that you don't have enough time to spend with a particular patient because you have other things happening in labor ward, I always refer to labor ward because this is where we spend a lot of, like the trainees or consultants, we spend a lot of time in labor ward. And the other thing is looking at all the reports of adverse events. As I said earlier, the majority of them are related to CTG malinterpretation. So a lot of things can happen in labor ward due to lack of situation awareness. Though we say lack of situation awareness or loss of situation awareness, there is like people try to move away from this loss of situation awareness because they say that it sounds as if we are blaming the person. I tried hard to change to lack of situation awareness or not using loss of situation awareness, but I cannot explain it otherwise. If there is a mistake happening and we analyze it, we take into consideration all the human factors. There is always the element of loss of situational awareness. Continuous update. As Wasim Lodi said earlier, you go back to your board. Labor board is very dynamic. And you see a patient at 7 o'clock in the morning in room 1, maybe at 2 o'clock in the afternoon, it's not the same patient. So you really need to keep yourself well informed about what's happening in your unit or during your shift. So going back and going back not on your own, go back with the team. It's always good to hear it from people who've been seeing the patient or the sister in charge, and just keep yourself updated. And very important, if you think that you're losing your situation awareness, just speak up. Just tell people around you. If you're not managing to answer the three questions, what's happening, why it's happening, and what's going to happen, then there is a problem. And this is where you seek help. Okay, so we talked about distraction. Very important to find ways of limiting distractions. The pilot has 2 crucial times, taking off and landing. And during that time, the cockpit is locked because nobody is allowed to go and distract them. We use it in healthcare. During, when the nurses have to give medication, we used to have it in our unit that they wear an apron saying, what is it, why? Medication round, yes. So they wear the apron with medication round, and nobody is allowed to talk to them. Nobody is allowed to distract them. Saying that, yes, it's good to have it, but providing that there is someone else looking after the unit. You cannot have a nurse looking after 4 or 5 patients, and you ask her to do the medication round without being interrupted. It means that she needs to hand over the other 4 or 5 patients to another one to keep that helicopter view. Fatigue, how can we tackle fatigue? When you are doing a shift, you need to have breaks. You need to speak to the sister in charge. Usually in the UK we have a system where you have 2 registrars on call, 1 SHO. It depends on the unit, but like majority of big units, you have at least 2 registrars and SHO on call in the middle of the night. So it's very important to communicate to people that you need that 15, 20 minutes break, and you can hand over the bleep to your colleagues and try to recover to be able to look after patients. And of course, managing lifestyle outside that shift is very important. Tax fixation. What do we mean by tax fixation? Anyone? Okay, yeah? Anyone else? So let's say I'm doing cesarean section and the patient is bleeding. I'm suturing and I'm fixated on that bleeding and I keep suturing. So I'm fixated on that bleeding and trying to stop it. One thing that will happen, I will lose track of time and I will lose track of how much bleeding is happening. Now, I know what's happening, there's bleeding and my sutures are not helping. So I need to think, I need to understand what's happening. Maybe the patient is going in DIC, And no matter how many sutures I'll put, it's not going to stop. So at this stage, I need to project and plan ahead. So I'm going to stop what I'm doing. I'm going to ask the anesthetist to correct the coagulopathy, put a pack, and wait. So here, tax fixation wasn't good because I lost track of what was happening. But in some occasions, tax fixation can help you, providing that you tell the people around you that I'm going to focus on stopping the bleeding. I would like you to focus on the suturing, or like you allocate and you inform people that you are going to focus only on repairing the tear or something, and then give other tasks to other people. Confirmation bias, we see it a lot when we are asked to review the CTG, or what we call a fresh eye. So the midwife will come to you and say she would like you to review her CTG and whether confirm or tell her if there is anything wrong. So one thing that you don't want to do is, or even if it's like you are the one asking somebody to review your CTG, don't go and say, this CTG looks normal, doesn't it? The minute you tell me that, especially if I'm doing a shift in the middle of the night, yeah, you think it's fine, you think it's normal, then it's normal. I'm not going to go and look at, review the patient, look at the risk factors. As I said, labor ward is very dynamic. A patient who starts being low risk at the beginning of the shift can become very high risk after 4 or 5 hours of labor. So always avoid confirmation bias and look at your patients as if this is the first time you are seeing her. Always go back, look at her risk factors, look at the progress, look at previous CTGs as well that can help you to identify the difference between different CTGs. Complacency. I think the more experienced we become, the more complacent we are, isn't it? Because we've seen it, we have experience with that, we know what's going to happen, so we don't bother to go step by step, A, B, C, D, and identify any risk. Just because of our experience, we think we know it, and we know what's going to happen. This is dangerous because this is where we can miss details. Deviation from SOP is very important to, not important to avoid, but important not to do, yeah. So SOPs, protocols, and guidelines are there to provide safe care, and I see it as protecting the healthcare as well, healthcare professionals. Because when we make mistakes or something goes wrong, when they investigate, the first thing they will take is what are we using as standards. They will go back to your protocol, they will go back to your SOP and ask whether you follow that protocol. I give you an example. In our early pregnancy unit, we do MVAs, manual vacuum aspiration. There was a patient with a BMI of 50 who was referred to early pregnancy because she had a dating scan and it was a missed miscarriage. She had 3 previous sections and she started bleeding a little bit. So the plan was to do MVA because the sac was very small, CRL of 3-4 millimeter, no heartbeat. And our protocol says BMI over 40, I think, yeah, 40. It's a contraindication to MVA in the unit, and previous section as well. So sometimes I deviate from the protocol because it's not because I'm the APAU lead, no, don't get me wrong, but I look at the patient, I scan her myself, I see that the sac is very high. She's a little bit of high BMI. She has risk for the general anesthetic. So I assess and think that she's suitable for MVA. I'm going to do it in the unit. I take responsibility and do it myself. I go because I know where the sac is. I'll do the procedure, and the patient is okay with that. So that case who came to EPAU said BMI of 50, 3 previous section, referred from antenatal clinic with images of missed miscarriage. In antenatal clinic, they did a transabdominal scan showing the sac with no heartbeat in a very small CRL. The patient had MVA, very experienced doctor, and she started bleeding. And she bled profusely. They couldn't stop the bleeding, and she needed to go to theater. Now, her BMI of 50 is not going to help to transfer her from the unit, and the unit is a little bit far from our main theaters. Looking back, that patient had a scar ectopic which was missed because she wasn't assessed properly. Even if the decision was made to do MVA, it would have been good to rescan, do transvaginal scan, assess the scar, because not enough information were given to the doctor who performed the procedure. So maybe if the doctor knew that she's 3 previous section and nobody did transvaginal scan, or they couldn't see the sac in relation to the scar, that's why they didn't think that it could be a scar ectopic. It's very easy for us to say it retrospectively, but this is just to say, if we stick to the protocol, if they read the guidelines, that patient wasn't suitable to be done in an outpatient setting. And we talked about lack of information. The more information you gather, the better for you, and that will help you to plan effectively, and effective communication as well. Okay. Just the last slide on just a mnemonic, how you can maintain your situational awareness. So Pack Us Up is prepare through a comprehensive briefing. So this is gathering your information. Acknowledge potential problems. So just again, this is gathering information regarding risk factors and how they can help you to identify any problem. Communicate well with your team. And use all information sources and update and revise your mental model, which is very important, and share it with your team as well. This is what will help you to be saved, actually. Your team can save you if you lose your situational awareness. And that will be the end of my talk. Thank you very much.
Thank you, Dr. Shehrzad, for such a valuable and enlightening talk. Now we will start our first session, which is on human factors. Our first speaker of the session is Dr. Wasim Lodi. He is LGC chair from Pakistan at RCOG. He is a co-organizer of RCOG masterclasses in massive obstetric hemorrhage, and he has facilitated at harassment and undermining workshops nationally. He is an accredited human factor facilitator and teaches crew management to clinicians and healthcare professionals. I now request Dr. Wasim Lodi to kindly come up to the stage to give us an insight on why do we make mistakes.
Assalamu alaikum and good morning, everyone. So thank you, Dr. Shima, for this glorious introduction. So I'm very passionate about this topic, why we make mistakes, and I have been, or in general, human factors. I've been doing it for last couple of years, especially in Pakistan, because here people, they believe they don't make any mistakes, and especially the more senior you become, I'm sorry to say that people, they think they are perfect. And this is the myth that I think we need to break. Secondly, most of the time when things go wrong, worldwide people then start looking into those incidents and see what we can learn from them, just to make sure that they don't happen again. But here, a lot of time, people would say, Allah ki marzi, aise hi hona tha, uska waqt aa gaya, aur wo chali gayi, ya bacha chala gaya ya chali gayi. So, this is something what I've learned from my experience of working in the UK for last 23 years now, almost. And I think we need to bring these things to Pakistan as well, and people need to start thinking differently, especially as Pakistan is going to become an MRCOG exam center. And then if you want to prepare yourself while you are here, then you have to think as if you are working in the UK or rest of the world. Okay, I will start by showing you a video, and then we'll discuss further.
I know in this situation an apology is not enough, but from the heart of this hospital I'm here to offer one. Your wife suffered what we refer to as a never event, something that should never happen.
Hospital on April 12th of 2016, and we expect it to be the happiest day of our lives.
You're gonna be okay. Everything is gonna be okay. All right, I'll take it from here.
The doctor tells me she'll be back in 15 minutes. 15 minutes. And that was the last time I saw my wife alive.
This happens far too often to women of every color.
But it's 4 times more likely to happen to black women. That's a fact.
The way that she touches people's lives and the way that her story resonates with people never ceases to amaze me. And I'm so honored to see these talented, gifted actors pouring their hearts into these roles. What we've accomplished together here with the residents, just couldn't have a better time for us to rally and come together and raise awareness about this issue.
The United States is the most dangerous country in the developed world to give birth in. There's no excuse for that.
Women all over this country deserve better. There's no statistic that can quantify what it's like to tell an 18-month-old that his mother's never coming home.
There's nothing I can do to bring Kira back, but the highest honor that I can pay Kira is to make sure I do everything I can to send other mothers home with their precious babies.
Right, so we all work in a very highly pressured specialty and also very highly litigious specialty as well. And I was hoping that in today's session I will be able to have some presentation from or representation from some of the other units, surgical departments as well. And I think I did ask Professor Nazli to open this invitation for other colleagues as well to come and learn from all this. So despite that there is a learning culture in the UK, still almost 700 never events happened in UK between April 2018 till July 2019. So why do we then keep having all these things despite learning from them?
I know in this situation an apology is not enough.
Can you move it?
I know.
Okay, so that's my hospital just for reference purposes. Right, so the most important conflict of interest I have is I still make mistakes. Yes, I learn from them. I'm a very reflective type of learner. And even if somebody else has made a mistake, I want to learn from it just to make sure that I do not repeat that. So in this session, hopefully by the time you leave this theater, you will have some understanding that why we make mistakes, and also it is okay to accept that we all make mistakes, and that is the most important thing. And I think it's my plea to especially my seniors, my other peers who are senior colleagues, that if we start accepting that I make mistakes, your juniors, they will start owning up rather than trying to cover them up and brush it under the carpet. And that's how we will improve maternal safety and child safety as well, because we have got two patients basically, baby and mother, to look after. Right, so is there anybody who has never made a mistake in life? Anybody can raise their hand? None. So it's that's normal. We all make mistakes. But then, where things go wrong is that we will not raise our hand to say that I made a mistake and this is the mistake, learn from me. As a consultant, have you ever said this to your juniors? Oh, day before yesterday or a year ago, I made this mistake and I want you to learn from it and don't make that mistake. Are you open to that idea? Okay. That's good to hear that. That's very good to hear that. Because if we do that, then we can foster that culture where juniors, they will start owning up to their mistakes. And it's not abnormal. This is not abnormal at all. So the question is, why do we make mistakes? So there are two reasons for that. One is technical factors and non-technical factors. If you don't know how to perform a certain procedure and you embark on that, say you are an ST1, you have not even done a simple cesarean section and you say, I'm going to do a placenta previa because that woman turned up in the middle of the night in a government hospital. You are not the best person to do that. If you're going to do that, you will end up having serious consequences of that. So fortunately, we have a system that nobody will let you go rogue and do that. So, but there are times, I know that in Pakistan, a lot of doctors, they do 6 months house job in obs and gynae after graduation and they write on their signboard, specialist, obstetrician, gynecologist. We have that culture, isn't it? Especially if you go and work in a small hospital and there are DIs and these LHVs, lady health visitors, who call themselves as specialists and they practice obs and gynae, which is very, very wrong. So fortunately, there is a check, especially if you're working in a reasonable place, then you will not do anything that you cannot do. So that is the commonest things, and you practice within the confines of your competence. So there have been a lot of research going on into trying to find the cause for why we make mistakes, and surgical specialties in general. They have been under a lot of pressure because of that. And surgeons also, they continue to make mistakes on their side as well. The other factor is non-technical factors. Now, non-technical factors are the sort of things that we will talk about in the next couple of sessions. And they are important because these are softer skills that we don't realize, but then they work. And they make us prone to making mistakes. And that is the learning point from them. And my other colleagues are going to talk about that, so I will leave a couple of things as it is. Some studies have shown that in UK, Australia, US, New Zealand, they say that about 10% of patients who get admitted to a hospital, they will suffer from some sort of medical error. It's a very big number, isn't it? 10%. And out of those 10% patients, at least 40%, they are surgical patients. And then out of those 40% of that 10%, more than 50% of these things, they end up in operating theater. You bring in a wrong patient, you do something. I mean, it's fortunately in maternity, it's very unlikely that you will bring a non-pregnant patient to theater to do a cesarean section. But then it can happen in gynecology. Instead of removing right ovary, you end up removing left ovary. Has it ever happened to you? No. So you think it cannot happen? Yeah, it can happen because recently in our hospital there were patients who were brought for an injection in the eye. A patient just followed the porter, came to theater. Nobody really checked properly because those patients, they had similar names. And the patient kept on getting wrong injection in the wrong eye, right injection in the wrong eye. And when they went for follow-up, said that my vision hasn't improved. And when they looked into that, they discovered he was having injection in the wrong eye. So it can happen. So we are not prone to that. So we can still make mistakes, and then if you further analyze that why do we make mistakes, almost 75% of the mistakes which happen within those non-technical factors, they are because of these non-technical factors. 20% are because of organizational factors. Say you have shortage of staff, you are under a lot of pressure, complex cases, things like that. And these are the main reasons. A lot of time, unfortunately, when things go wrong, it's a common practice to find a scapegoat and put that this happened because of this person. So it's not that person, because even if you remove that person, doctor, resident doctor, or a trainee from the job, it's not going to change anything, because inherently there are other factors which are there, and this is where then you can bring in a change. So the other factors which make a difference are communication, team working, leadership, decision making, situational awareness, and surprise, stress and fatigue. A lot of time you feel that no, I can sleep for 3 hours and still function next day. We cannot, unfortunately. And do you know, 1 night sleep deprivation is equivalent to 0.1% of alcohol in your blood. So imagine if you have been doing it after 2-3 nights sleep deprivation, then you are as dangerous as any alcoholic operating on a patient. Right, so this is a very interesting video. I would highly recommend, watch it on YouTube. It's a guy called Brian Goldman. He's a physician and a journalist as well. So he talks about these human factors and the concept of making mistakes. So the background to this is, it's a 20-minute video. I've just edited it. So this bit that I've taken is from that video. The context is that when he was a resident, he saw a patient in A&E who came with some chest pain, and then he saw her. He thought it was okay. He asked one of the nurses for confirmation. She also felt that she's okay. She can go home, and especially as A&Es in US and UK are very busy. So the woman went home, and then normally when he goes home, he never went back through A&E. That day he kept on feeling uncomfortable. Then in the evening he decided to go home via A&E. So when he was going through that, one of the other nurses came to him and said that, do you remember you saw that patient in the morning and you sent home? And then she was readmitted and she has gone to ICU. Because she was unwell, just a couple of hours after he discharged her from A&E. And then that woman unfortunately passed away after a couple of days, and that had a profound impact on him. And that's why the words that he has been using, do you remember? And it's common, isn't it? Like if you have done something wrong, you know you have done something wrong, and then you keep waiting, and as soon as somebody mentions to you that you saw that patient the other day, and all of a sudden you do remember. It happens to you, isn't it? So something goes wrong and say, oh, you operated on this patient. Did she come back? Or somebody has come with something and you will say, did I operate on her? It happens, isn't it? So have a look at it. Can you play that, please?
After Mrs. Drucker before, but another nurse said 3 words to me that are the 3 words that most emergency physicians I know dread. Others in medicine dread them as well, but there's something particular about emergency medicine because we see patients so fleetingly. The 3 words are, do you remember? Do you remember that patient you sent home? The other nurse asked matter-of-factly. Well, she's back, in just that tone of voice. Well, she was back all right. She was back in near death. About an hour after she had arrived home, after I'd sent her home, she collapsed. And her family called 911, and the paramedics brought her back to the emergency department, where she had a blood pressure of 50, which is in severe shock. And she was barely breathing, and she was blue. And the emerge staff pulled out all the stops They gave her medications to raise her blood pressure. They put her on a ventilator.
इसको रोक दें. Okay, so you all know the cliche, to err is human, isn't it? कि इंसान क्या कहते हैं, इंसान खता का पुतला है. तो unfortunately ये सब चीज़ें जो हैं हम एक्सेप्ट तो करते हैं, लेकिन उसके बाद उसके इन्वेस्टिगेशन नहीं करते. We don't further investigate and the inquiry stops there, that okay, to err is human. So do you know 70% of airplane crashes, they happen because of non-technical factors. Almost 90% of car accidents, they happen because of that. Yes, there is a small percentage if a young boy takes the car out and then goes out, but most of the time it won't happen because cars are very expensive. So parents would be very concerned about that. But then a lot of times you don't pay attention when you are on the road, and that's how accidents they happen. And you know that the modern cars, they have their dashboard, there is a lot of information over there. And then if you try to look at all that, it distracts you. I find that very distracting. Do you find it distracting? If you go back to the days when you would have a simple radio on the car, that was, I think, a safer time. Now having a Tesla or another modern car with a whole computer fitted inside, and you try to play while driving and trying to listen to the phone, so it becomes very distracting. Do you do that? You do that, so which we shouldn't be doing. So you cannot talk on the mobile phone and drive as well at the same time. Similarly, workplace accidents, if you investigate, 90% of them, they happen because of non-technical factors. RCOG has recognized the need for this, and RCOG started working on it for last few years. We have these non-technical skills for surgeons called NOTS, part of curriculum, training curriculum over there. And as we are going to have exams here in Pakistan as well, so as trainers, you need to introduce these sort of new developments into the curriculum and into the practice, so that people who are taking the exams, they are well versed with what to do in this sort of situation. And Rani has organized, she's also, I think, a very passionate person for human factors, and she recently organized a workshop at the college called Human Factors in Maternity, which was very well attended. And I think when we looked at the feedback of that, it was really heartwarming. And it's just that you just need few people to sit together. One person starts bringing up their emotions or how they made a mistake, what went wrong. And others, they start melting as well. And then everybody starts happy sharing their mistakes. So this is one of the, this picture is from that knots that we use on labor ward. So if you look at it, it's very simple. There is nothing fancy about it. All this is on Royal College website. It's part of training for the trainees over there, but for trainees in Pakistan as well, you can introduce that. And if I'm a trainee in UK, I don't have to have it done by my consultant or one of my senior registrars. It could be done by a midwife in charge for labor ward, because I can say to her, I'm conducting a ward round. Can you please fill in this as we are going around? She will not have to talk to you. She will just observe how was your behavior, how are you making the decisions, how are you communicating with your rest of the team, and in general, how you led that ward round. So I would encourage that people who are working here as residents, as trainees, even as consultants, they can utilize it in their practice. And then that will bring in a change, because essentially what it is doing is, it is giving you insight into your blind self. So this is what we call Johari's window in medical education. So if you look on this column, top right one, blind self. So these are the things about you that others know, but you do not know, because people are looking at you and they see that you are making a mistake or you are not behaving in a particular way, and this is where that you need to get insight, and others, they can tell you, and you can improve yourself. So when we go through adverse events, they have a profound impact on us. And if I remember the first baby which died because of me, when I started Obs and Gynae training in Lahore in 1998 with Professor Saeed, and I was supposed to sit with a patient watching CTG. At that time, we didn't have that sort of formal training system for CTGs. We used to call it NST, non-stress test at that time. I sat with the patient. It's not that I was not sitting with her. I sat with her, but I failed to recognize that CTG. It was having decelerations, then it started becoming like a straight line, and then ultimately the baby died. The heartbeat was still there when it was just pre-terminal, actually, when fortunately one of my senior registrars walked in. It was around 4 o'clock in the morning. And she looked at it and she said, "This is horrible, we need to go to theater." So we went to theater for a crash section. And unfortunately, the baby died, caught gases of 6.9 or something like that. And then I realized for the first time that I have killed a baby. That's how I felt. And next day, when Professor Saeed called me to his office, I was just crying my eyes out. I was just like, you know, that feeling that I have killed this baby. I could have saved that baby if I was awake. That I was probably nodding off while I was sitting on a chair. And I didn't recognize. So unfortunately, because I'm talking about good 26 years ago, so we had no system of investigating at that time, and it would be that, okay, it has happened, it's your fault, and all that. Now when I look back, there were human factors involved into that incident, and I have used that as a learning exercise for myself, and all these things that we will talk about later, stress, fatigue, those things, they contributed to that. So I've never forgotten that incident. I still remember that. And as the previous video shows, do you remember? I do remember. And I'm sure all of you would have a similar story to that. And you can use that to improve yourself. Isko play kijiye.
The things I'm going to talk about today, the stories I'm going to tell, they're actually very difficult for me. So if my voice falters or if tears come to my eyes, I'll apologize now before I get started. Everything I'm going to talk about today, it's all been on my blog. I'll always remember it as the day medicine broke my chief. I went to medical school at Northwestern University, and as a third-year student, one of the hardest rotations was obstetrics gynecology. And the reason why is we worked 24 to 36 hours in a row, and the residents, they were tough, they were smart, and they scared the heck out of us. One morning, when I was at morning rounds and we were going over all the patients who were actively in labor, we were sitting there going over the board, I was standing right next to my chief resident. And my eyes were kind of closing because I'd been up all night and I was tired, but my chief resident's pager went off and I noticed that she looked at it, and out of the corner of my eye I could see it said, "Emergency room, 911. When your pager says emergency room 911, you don't pick up the phone, you go. She looked at me, looked at the door, and we both took off. We ran down the stairs, walked out into the cold Chicago winter across the street, and before you know it, we were in the emergency room. Now, I was a third-year medical student. I didn't have a lot of experience. So when I walked in that emergency room and it was empty, I didn't realize something was wrong. It was empty because every single staff member was in the trauma bay. The only one left over was the secretary, and she looked at us and kind of pointed her head. When we walked in, I had no idea what I was about to walk into. The patient was in her 20s. When I looked down at her belly, it was big and swollen because she was 37 weeks pregnant. And she was bleeding from her neck. There was blood everywhere. Apparently, her boyfriend, the father of the baby, had stabbed her in the neck. My chief knew exactly what to do. She looked at me, she said, "Get me a gown, get me some gloves, get me some equipment." I ran out, I found the secretary, I had no idea where anything was in the emergency room, and she helped me find the things. We bring it back in. I helped the chief sterilely gown and glove. I prepared the operative site, I put the betadine on the belly. All the while, an emergency room physician and a trauma physician were sitting at the patient's neck, trying their best to get this bleeding under control, and they were doing a lousy job at it. The chief and I looked up. We looked over the fetal monitor, and of course, we're looking at the fetal heart rate. The heart rate's 140s, 145, 130s, 120s. My chief started to get a little nervous. Come on, guys, we got to do something. I can get this baby out. I can have this baby out in seconds. The trauma surgeon barks back at us. Patient's not stable enough, you'll kill her. So we waited. My chief was sitting there. She had her scalpel in her hand. She was sterilely gowned. She was ready. She knew that she could be into that belly, scalpel wielding, could have that baby out in no time. Heart rate goes down to 110s, 100s. Now we're getting really nervous. Again, she speaks up. It's now or never. We either take this baby out or it's dying. Right at that moment, the patient's heart monitor started beeping. Ventricular fibrillation. The ER doc goes and turns around, grabs the paddles, put them on the patient's chest. The trauma physician, trying to clear the field, steps back. Everyone clear. His hand goes right into the chief's belly. She had lifted her scalpel so she didn't cut him. She falls backwards, falling against the wall. Half sitting, half standing, trying not to break her sterility because she still wants to get in that belly if she needs to, but also not trying to cut herself or hurt anyone. 1 shock, 2 shocks, 3 shocks, asystole, flatline. Mother died. Baby died also. We walked away into the cold air, back up the stairs, and neither the chief or I really knew what to say. I mean, what do you say? This poor person died. I didn't have the repertoire. I was a third-year medical student. I had never seen anything like this. But the chief didn't either, and she didn't know what to say. And when we got back to the floor, she went and she sat in the nursing station, and for the first 30 minutes, all she wanted to do was talk. So every person who came by, a nurse, a student, a resident, she went over and over again, trying to figure out what could we have done that was different? How could we have saved these people's lives? After that, she became really quiet. And she sat there at the table, and her eyes were glazed over, and you could see her hands go up occasionally because she thought she was still there with that scalpel. She was still reliving the moment. How could we have done things differently? And last of all, she started to cry. And it was horrible. There she was at the table, sobbing her eyes out, and none of us knew what to do. Because she was our chief. She was our rock. We had no idea how we were going to make this better. Eventually, she took her pager, took it off, put it on the table, and walked away. And there I was, sitting at the table with this pager. 20 minutes later, an attending came and he got me, grabbed the pager. I finished off my 36-hour shift. I went home and I went to sleep. When I came back the next day, there was my chief at rounds. Not a word. We never talked about it again. She never discussed it. She didn't discuss it with the staff. It was like it never happened. My chief eventually left. She went to another academic center and she made a big name for herself. But I'll always remember that as the day that medicine broke my chief. Because I knew she'd never be the same. Like a soldier in battle, she had seen her first blood. She had seen her first kill. And you can never go back after that. And I know.
Right, so I'm sure we all have stories like that, and the important thing is, again, to reflect on it and learn from it. I'm just going to speed up a little bit because I'm already running late.
The things
Okay, now when we make mistakes, so there are multiple factors. As I mentioned, situational awareness is one of that. We have a session on it, fixation errors, change blindness, systemic biases, inattentional blindness, hierarchy, and fatigue, stress, ergonomics, how things are designed. So there are a lot of factors. I mean, it's like a full day workshop on its own. So we have tried to address a couple of things, and my colleagues, they will talk about it later. And also another thing where we make mistake is what we can consider rapid fire analysis, that if they call you to go and see a CTG on labor ward, and then you walk in, you look at the CTG, no, this looks normal to me, this looks abnormal, or she needs a cesarean section. It happens, isn't it? We all do that. Because what we are relying on is we are tapping on our memory in the brain and pattern recognition of that CTG by which we are deciding whether we need to take her for a cesarean section or not. And that also is a wrong approach, because what you need is you need to actually look into the background of that, because unless you do that, you will not be able to make a right judgment and you will miss things. And your decision for a cesarean section or not for a cesarean section will be wrong. And that's why we have WHO checklist to be used during just before the operation or any procedure, and S-bar tool for the communication and handover. So it is important that we don't rely on our memory. And then, can we still end up avoiding making mistakes? No. Whatever you are going to do, you will learn from one mistake, but next time you will make a new mistake. And there is not much that you can do about that. But what you need to know is to have that awareness that the tiniest little change in circumstances can have big impact on people's behavior. Sometimes the hospital administration decides that, okay, we are not going to do this on labor ward, this will happen in the clinic. And that could have an impact on how the clinicians, they work. And also, sometimes the environment is so toxic or really difficult to work that people are not happy. And remember that happy people are less prone to errors. And in my next talk, I will talk about that. So I have another talk tomorrow on the role of non-technical skills in minimal access surgery, which is essentially an extension of the presentation from today. So we'll talk more things tomorrow. So I'm just going to say that if you have a look at this video, Brian Goldman, just go on YouTube, find it, and have a look at it. Okay, so I will stop here, and if you have any questions, I'm happy to take it. Thank you.
So audience, I would like to inform you all that we have a little made slight changes in our schedule. So Dr. Y will be delivering his talk at 11:30 instead of now. For the moment, we have circulated already the indemnity forms. All audience are requested to fill the forms and return to us at the earliest convenient possible time. After filling the forms and handing over the forms to us, they are requested to visit the poster area, which will be a very wonderful opportunity to explore the insightful work and contributions showcased there. Tea will be served at sharp 11 in the front lawn, and after at 11:30 we will be starting again from our next presentation. Thank you very much.
Good morning, everyone. I'm Rabia. So medical indemnity is something which is very close to my heart, and filling this pro forma is actually part of that. If a doctor in UK happens to make a mistake, there are mechanisms to protect them. And I feel for us as well, there needs to be some mechanism where we can offer this protection to our doctors. So medical indemnity insurance is where there is small fee that a doctor pays, as a result of which they are given protection, they are given legal advice where and when needed. And all the doctors need to have that medical insurance before starting medical practice. My concern is that we are unable to offer this protection to our doctors, especially the young ones. Think about it, even if something goes wrong, many a times hospital wants to protect itself. It's not that individual doctor. Usually there is someone who is put under the bus. There is one individual that gets blamed for a mistake that is made, rather than thinking that it is a system error and we need to improve the system. What we are trying to do is get information from you. How can we organize a system which is low cost and is useful for all of us, for doctors, junior and senior? How can we do it? We can do it by collaboration. All of you would have ideas which can help us. All of you would know somebody. You may know a lawyer who is good, who can be of help. If your friend was in trouble and you would say, hey, go to that lawyer, I know he is really good. Or you may say, please go to that doctor, I know he has been through this and will be able to help you. So formation of this pro forma is basically getting that information from all of you and seeing what we can do with it for future, and maybe we can come up with an indemnity scheme for our doctors which is low cost, if not free at all. So if you look at the pro forma, it talks about where do you work, because the aim is to get Pakistani doctors' opinion about it. The capacity you work in, because consultants tend to have a different experience from trainees. If you are a consultant in public sector, private organization, or you are a solo practitioner doctors are probably the most lonely ones, and I feel that they need that protection as well. Similarly, if you're working in private organizations, sometimes it is the organization which takes priority rather than the doctor and their safety. And have you been a member of an indemnity scheme? If you are, we would love to hear about that. And if no, then do you know of any existing medical indemnity scheme in the country, and which ones? And if we were to support something like that, can you name one professional you can think of who could be instrumental in providing this information to support the community of the doctor? It doesn't necessarily has to be a doctor. It can be a non-doctor, it can be a lawyer, it can be someone who knows PMDC better, who knows healthcare commissions better. And what is a reasonable annual membership fee for such a scheme at your professional level? So, and one idea that you would like to put forward for this cause. If you could please write your name, email, and WhatsApp number so that if there is any development on it, we can contact you, and if we need any more information, we should be able to contact you. So the idea is that this conference is not just talk, but we can get something practical out of it for our own doctors. So any questions, please, and any ideas that you can throw up, because I feel all of us, if we contribute little, we might be able to help a lot for our future generations, especially if I see doctors are one of the least united people, and IRC has given us a forum where we have come united, whether we are fellows of College of Physicians and Surgeons Pakistan or whether we are fellows of Royal College. We have become united, and if we can take this union further, that would be lovely. Thank you so much. Any questions, please ask. So we should have that information available to us from the professional who should be one phone call away to guide us how to write a statement, have a look at it. And it's not about telling a lie, it's more about getting the right help at the time of need. When a mistake happens, if today it is me, tomorrow it can be anyone else as well. Or if it is today a colleague of mine, tomorrow it could be me as well. And only if we start supporting each other, only then we would be able to voice it and say that this mistake has been made. And only then we can rectify it and we can correct it.
I have a question, please.
Please.
I'm a junior consultant. आप प्लीज़ मुझे कुछ इंसाइट दे सकती हैं कि यूके में जब कोई डॉक्टर मिस्टेक करता है तो वहाँ का सिस्टम कैसे स्ट्रॉन्ग है और कैसे उसको डील करते हैं?
Yeah, so thank you. That's a very lovely question. So I have worked there for 11 years. पहली बात तो ये कि वो जो एक ऑनेस्ट अप्रोच है कि अगर मैं उठ के ये कहूँ कि this happened in the night while I was on call and I could have done this better. तो मेरी शायद गर्दन नहीं उतारी जाएगी in the morning. That's what's different. They would say, all right, this could have been done better. How can we make it better? The thought process is that it is not one person that makes a mistake. For example, अगर एक जैसे डॉक्टर वसीम बात कर रहे थे कि a baby died, अगर CTG की interpretation नहीं हुई, तो उस पर बहुत सारे checks थे, उसके risk factors देखने के लिए. There's a midwife to see, there's a senior midwife with her, then there is a junior doctor, then there is a senior doctor to see. Anybody can say, I'm not happy with what is happening. और इसके बावजूद अगर हो जाता है, they would ask you to write a statement, and you need to write it putting your feelings aside, just the objective, this happened and this happened. और अगर आपसे वो ये नहीं भी कह रहे, ये केस कहीं पे कोर्ट में नहीं भी जा रहा, they will ask you कि अगर एक इवेंट हुआ है, write it down and keep it with you, क्योंकि आप वक्त गुजरने के बाद आप भूल जाएंगे what had happened. Nobody is going to lie for you, even your best friend is going to tell the truth. And honesty is the best policy. अगर आप एक बार कुछ झूठ बोलते हैं, then as a result of which आपकी सारी statement गलत मान ली जाती है. When this happens, for example, if I am insured, I would pick up the phone, I would call MDU or I would call MPS, जिस किसी की मेरी membership होगी, और मैं उनसे कहूँगी कि this is what has happened in the night. For example, small सी example है, I was doing a cesarean section and there was a cut on the baby's cheek. And this has happened. They would ask me, I think explain it to the patient, tell them, you're sorry it happened, and this happened because liker kam tha, baby ki position aisi thi, it was very thick, it was bleeding a lot, and write it down with you. The patient and her husband, they can claim later on कि बच्चे का cosmetics खराब हुआ है, उसके चेहरे पे scar आया है. Then the hospital will review the notes and they will try to settle it for you without involving you at all. अगर एक डॉक्टर को उन्हें इन्वॉल्व करना पड़ा है या केस कोर्ट में चला गया है, उस सूरत में जो आपकी इंडेमनिटी या इंश्योरेंस कंपनी है वो आपको लॉयर प्रोवाइड करेगी जिसको आप पे कर रहे थे. आपको हॉस्पिटल की तरफ से भी लॉयर मिल रहा है, लेकिन आपकी अपनी पर्सनल प्रोटेक्शन के लिए आपका जो इंडेमनिटी लॉयर है दैट इज़ ऑल्सो हेल्पिंग यू, एंड देन यू गो टू कोर्ट विद दैट. द चांस ऑफ हैविंग के क्रिमिनल चार्जेस एक डॉक्टर पे आएंगे इज़ वेरी, इट वुड बी अ रेयर हैपनिंग दैट इट हैपन्स. फॉर एग्जाम्पल देयर वॉज अ केस, अगर आपको याद हो, बाबा गारबा केस उसको कहते हैं. देयर वॉज अ पीडियाट्रिक रजिस्ट्रार जो कि बहुत बिजी थी, और उसकी बिजीनेस में देयर वॉज अ चाइल्ड जिसका CPR हो रहा था, एंड शी केम इन द रूम एंड शी सेड कि पेरेंट्स ने DNR डू नॉट रिसेसिटेट का फॉर्म साइन किया हुआ है. एवरीबडी स्टॉप फॉर अ मिनट, शी लुक थ्रू द नोट्स एंड शी रियलाइज शी इज़ टॉकिंग अबाउट द रॉन्ग बेबी. वो एक और बच्चा था जिसका DNR साइन हुआ था. दे रीस्टार्टेड CPR in 1 minute's time. However, it became such a big mistake that it went all the way to the court, and when they look at the factors, it was not that one doctor's mistake. She was very busy, there was a lot of babies there, she was the only one there, the consultant was not there to help her, the junior midwife was present, locum पे काम कर रही थी जो nurse मौजूद थी. So there were multiple other factors. कोई शख्स घर से ये सोच के नहीं आता कि आज मैंने ये harm करके आना है. All of us are trying our best for thinking, and I feel कि हम जब पाकिस्तान में भी अपने juniors से बात करते हैं, rather than finding one person to blame, we need to look at the overall circumstances and have that situational awareness कि what had happened. We need to provide that support to the juniors, जहाँ वो खड़े होके मुझसे कह सकें, you know what, this happened to me in the night, because it doesn't happen to the patient only, it happens to the doctor as well. So they should be able to say that to us कि this is what happened to me in the night. And what could I have done better? मैं क्या बदल लेती? What should I do next time? They cannot think what can they do next time अगर हम डांट ही नहीं ख़त्म करेंगे तो. जब तक, और वो हम में से किसी के साथ भी हो सकता है. It could be any one of us. And that's why I feel कि we need to be more empathetic towards each other, especially to our junior doctors, and stand by them. So your forms would really help us formulate a plan, and maybe we can change the situation here. Thank you so much.
जब आप ट्रेनिंग के टाइम पे उसको डांटना शुरू कर देंगे तो वो उस वक्त से सीख जाएगी कि कैसे अपनी चीज़ों को अंडर द कारपेट हमने छुपाना और अपने आप को डिफेंड करना कैसे सीखना है, वो ये चीज़ सीख जाएगी ट्रेनिंग. तो दिस नीड टू बी एड्रेस.
एब्सोल्युटली. देखिए, एक बीवी को अगर शोहर से डांट पड़ती है ना एक्स्ट्रा शॉपिंग करने पे, वो अपनी शॉपिंग छुपानी शुरू कर देती है. तो व्हाट अबाउट ट्रेनिंग? तो एक बहुत बड़ी बात है, और उसमें होने वाली मिस्टेक्स दूसरों को अफेक्ट कर रही है.
बहुत सही कहा.
प्लीज.
अस्सलाम वालेकुम मैम.
अस्सलाम वालेकुम.
मैम, आपने भी थोड़ी देर पहले बताया कि एक हर कंप्लेंट का एक स्पेसिफिक टाइम पीरियड होता है
या
एक पेशेंट. तो हमें तो पहले अपने राइट्स का ही नहीं पता ना, हम डॉक्टर्स को.
एब्सोल्युटली.
हमें पहले ऐसी कोई हमें वेबसाइट मिले या कुछ ऐसा मिले जिसमें पहले हमें अपने राइट्स का पता चले, फिर हम उसके अगेंस्ट हमारे पास अवेयरनेस होगी तो एक सिस्टम डेवलप होगा. फर्स्ट ऑफ ऑल आई थिंक हम सबको ये अवेयरनेस होनी चाहिए कि हम अपने राइट्स के लिए स्पीक अप करें और फिर आगे जाके एक सिस्टम क्रिएट होगा.
वेरी ट्रू. और देखिए, लाइफ हैज़ बिकम सो, हम सब स्पेशलिटीज़ की बात करते हैं क्योंकि एक गायनोकोलॉजिस्ट को सब नहीं पता हो सकता, इजंट इट? सिमिलरली इस राइट की अवेयरनेस के लिए हमें राइट लॉयर्स जो मेडिकल लॉ के स्पेशलिस्ट हैं, जो स्पेसिफिकली उस फील्ड को डील करते हैं, दोज आर द पीपल दैट वी नीड ऑन बोर्ड for an idea like this to develop, that you know that on one phone call, I can call that person. और मेरा ख्याल है कि अगर उसके लिए even small contribution from a large number of people we can have, then if one of us is in trouble, rest of us are paying a little amount towards that. The culture in Pakistan is changing, the litigation is coming a lot, quite a bit. हमारा गुमान एक दूसरे से खराब हो चुका हुआ है. So I think it is very important that we support each other and help each other to protect.
Asma Jahangir's organization, that's a very strong organization, and that could be a starting point, because that organization is there for the rights, human rights and women rights. And if we are starting for our specialty, where majority are women, and then possibly they would be having lawyers who would be happy to work on this area. And that is the sort of collaboration that we need to work on. And then that would be a starting point.
So very valid suggestion, Professor Mariam. Thank you so much. Yeah, that can be a starting point. Similarly, other people who know organizations, people, or even people who have been through this. जो कोई हेल्थ केयर कमीशन की चक्की से एक बार गुजरता है, उसको भी बहुत कुछ पता चल जाता है. So anybody who can help us. So once we are done here, if we can move to the to see the posters. So quite colorful posters we've got here, and a lot of input from all of you. Really good to see so much work happening in Pakistan, and I think it's time that we project the work that we do and that does not get international representation. Thank you so much.
As we resume our workshop, the next presentation will be presented by Dr. Y. Yung. He is a consultant obstetrician and urogynecologist at North Middlesex University Hospital, an associate professor at St. George International School of Medicine. Dr. Y. Yung, please come forward on the stage for your presentation on the concept of never ends.
So we would also like to thank as our faculty, Professor Nazli, for inviting us. For Dr. Shahzad and myself, we're thrilled to be coming back for the second time. We were here last year. Okay? So I'm going to start off with playing this video. Now you notice that we play a lot of videos. And that's because it's easier to relate to how people make mistakes by looking at videos. Okay, can you play the video?
Patient's name is Mo Weinberg. Cancer is confined to the right testicle. Dr. Turk will be assisting with the removal.
Sorry, Mo. Looks like you're about to either lose Larry or Curly. Starting the incision.
Wait, stop. I'm guessing Mr. Weinberg is Jewish?
Yeah, so?
Why isn't he circumcised?
A recent medical study found that a mistake is made on about 20% of all patients. Most of these are clerical and harmless, but it still adds up to a lot of near misses.
Dr. Wen wants me to ask you if there could be a mix-up, because our appendicitis patient, that dude doesn't have an appendix.
Oh, wait right here.
Okay. So the audio isn't very clear, but what happened there really is that they were operating on the wrong patient. Okay, so they've done the wrong patient. So my name is Y. Yung. My area of interest is urogyne, and I also do V-notes. But I'm also a technical member of the Chartered Institute of Ergonomics and Human Factors. That means I've got a special interest in patient safety and human factors. Okay, so for the next 30 minutes or so, I'm going to be talking to you about the concept of never events. So in the United Kingdom, never events are things that should never happen, okay? Safety incidences that should never happen if all your practices are in place. Unfortunately, that's not gone down. So I'm going to be focusing on two areas that affect our specialty. That is wrong site surgery and retained swabs. So for myself and Wasim and Shahzad, our journey started a long time ago, and we started doing PPH workshops. The first one that we did was in Malaysia in 2012, and at that time, Dr. Taka was the convener of courses worldwide. Okay, so we've been to China, here in China. We've been to, this is Athens. This is, I think, Spain. And then later on, we started teaching on human factors, on non-technical skills. So we started working with British Airways. So here you can, oops. So here you can see, this is actually in Heathrow Airport, Terminal 4. All right, and here we are training in actually a flight simulator. It's actually very interesting. So we go in the flight simulator. It's like a play thing. And then the teacher will program the flight simulator so that you're landing in Karachi or Lahore or Kuala Lumpur or London. And they can make it foggy. They can make it rain. They can make it so that the fuel tank is empty. Okay? And you don't need any knowledge. All you need to know really is how to communicate. You need to make sure you're not fixated, etc. And what we find really is that it's very, very easy to make mistakes. Okay, so here is one of the, so Dr. Lodi was with us at the very, very beginning. This is the backstage of the flight simulator. Okay, so you can see myself there, Dr. Lodi and a few other people. And for us in the NHS in the United Kingdom, human factors is compulsory. A few years ago, the National Health Service signed a concordat or an agreement. And all our SHOs, all our medical students, all our nurses they're not experts in human factors, but they're aware of things like fatigue, situational awareness, distractions, checklists. Okay? So it's becoming more accepted now that we make mistakes, we try to minimize them. So Martin Bromley is a very famous patient safety advocate who's also a pilot. And his wife died in an accident about 15 years ago. And he said basically, as doctors, we focus on technical skills. So that means you guys are much more interested in knowing how to do the technical aspects of a hysterectomy. But you're not so keen on situational awareness or communication. Okay? And James Reason, he's the grandfather of human factors, and he says even the best people sometimes makes the worst mistakes. So today we'll be talking about what's wrong side surgery, what are the causes of it, why do we still have retained swabs, and what can we do to prevent this? Okay, so wrong side surgery, what does it mean? So it's quite interesting because I thought it's just the wrong side. But essentially, it could be the wrong side, so left instead of right. It could be the wrong site, meaning you're down to operate on your leg, but they operated on your eye instead. Okay? And it can also be wrong patient surgery, which has happened to me a few months ago, and I'll talk about that later. Now, in the UK, a few years ago, there are 43 cases of wrong side surgery. And it's indefensible. Okay, you can't defend that, so you pay out a lot of money. Okay, last year, how many cases do you think there were? Wrong side surgery. It's the same. So for the past 10 years, they've always been the same, around 40 cases of wrong side surgery. That's not changed, despite all the things we put in. Okay? So the commonest specialty is orthopedics, and the commonest operation is arthroscopy. Okay? And there are many reasons why it happens. So here, for example, is a typical hip operation. Which leg do you think is being operated on? Which leg? Right leg. But it's not that. If you were uninitiated, you wouldn't be sure. But you're right. This is basically operating on the right leg. This is a picture sent to me by one of my colleagues who's an anesthetist from France. And what happened really was that they were in a rush. They didn't do the checklist properly, and the orderly placed the wrong leg onto the traction boot, and they operate on the wrong leg, despite the WHO checklist being done. So, do you all do this? Yeah, so WHO checklist, first published in 2008, 19 domains in there, and it's reduced a lot of wrong side surgery. It reduced mortality by almost 50%. So have a good look. This is the WHO checklist. Now we learned a lot from aviation. This is a typical aviation aeroplane checklist. Okay? And this is another type of checklist. This was given to me by Dr. Lodi. I think his wife gave him shopping. Okay, now I've got a question for you. What is the difference between this checklist and this checklist? More what? More precise, okay. Sorry? Bit what? There are pictures on the other one, okay. So this one's got more pictures, okay. Anything else? This is not legible, okay. So you have to blame Dr. Lodi's wife. Okay, well, I didn't know this, but apparently there are two types of checklists. Okay, so the first type is called a challenge and response, which is this one. Okay, when you go to the theater, you'll notice it. Okay, someone will read out, there's a challenge, and then the team has to respond. Okay, that's the way it's supposed to be done, but quite often we don't do it like that. Okay, so challenge and response checklist. And this basically is a reminder. Okay, it's called a to-do checklist. I don't think he phones his wife and asks, challenge and then the response. So this is basically to do, a reminder. So there are two different types, and they serve different functions. Okay, so what is the aim of the WHO checklist? Do you know? Okay, so very interesting. So anyway, Atul Gawande, in 2008, his team was tasked to reduce errors, as you said. But when they designed the WHO checklist, the main aim was actually communication. Okay? And what I've learned from aviation people really is that as a clinician, you need two things. One really is you need to be humble and you need to be confident. Humility and confidence. So let's see what Atul has to say. Video, please.
The culture shift is without question. Embedded in the checklist is a set of values. It reflects humility to use a checklist, you must be humble enough to think that you might fail. You have to have a willingness to believe in discipline of following a checklist, and then teamwork, a belief. The checklist is fundamentally about having everybody communicate with one another, about the plans, blood ready, all of those kinds of things. And that teamwork aspect is also not something that we necessarily really embrace. Being able to make that set of values central to what a surgical system does.
Okay, so what he says there really is originally about teamwork, it's about communication, sharing the same mental model so that everybody knows, okay? And then also partly empowering the juniors to speak up, we'll talk about later, if they see something wrong, okay? So this is Martin Bromley, and his wife died in a medical error, and he founded this charity called Clinical Human Factors Group, okay? So in 2012, he wrote this paper. It's called Never. And it looks at 9 wrong side surgeries, okay, after the WHO checklist was done. Yeah? So even though you do the WHO checklist, there should be no wrong side surgery, but it happened. And then when they looked at it, it's a combination of things, why it happens. Okay? And we'll go through that in a little while. So these are the things. These are the reasons, essentially, why we do wrong side surgery. So lack of communication, complacency, distractions, which we'll talk about later, and lack of teamwork. These are the common things, okay? And then also things like pressure, workload, and then norms or deviations, which again I'll explain, okay? So sometimes I get called in to investigate why you injected the wrong eye, yeah, or why you operated on the wrong side. And quite often it's because you deviate from what's normal practice. And there are many reasons why people do that. One really is nobody cares. Sometimes it's too much workload. You do 10 cases, whereas you should be doing 5 cases. And because of workload, you cut corners, you do shortcuts. Sometimes it's task overload. And sometimes, basically, it's the absence of cross-checking. Very important thing, cross-checking, okay? So this is the original checklist paper, 2008. They looked at 8 hospitals worldwide and they put this in. Okay, so now in the UK, since 2009, it's mandatory for us to do this. So my question to you is, does the WHO checklist work? What do you think? Sorry? To some extent. What does that mean? Yes or no? Yes, okay, fine, all right. So why are we having wrong side surgery? So what's quite interesting really is that many people have tried to replicate this study. Okay? And sometimes some people say it works. Sometimes some people say it doesn't work. All right? And the common denominator is that it works if it's used correctly as a tool in a unit that's already safety conscious. But if you're not well taught, when we started doing the WHO checklist, Dr. Lodi was there with me, we weren't taught what to do. Okay? We didn't do a challenge and response, so we just ticked off everything. Okay? And then we didn't speak up when something was wrong. We just said it's taking too much time, so just rush through it. Okay? In those cases, the checklist won't work. And you have wrong side surgery and retained swabs. Okay? So you can see the first one. One of the misconceptions really is that the checklist will prevent never events. And the reality is that it's basically design and adherence to SOPs that actually make a difference. Okay, so this is what we do. My favorite slide, because it's got my name on it, why versus what. Okay, this is what human factors people say. WAD or WAD means work as done. Okay, and WAI means work as imagined. Okay, so the human factor specialist will say, work as imagined will be this path. That's what you should walk. Yeah, that's how you should do the WHO checklist. But because of workload, we actually take shortcuts. Yeah? And that's why sometimes we make mistakes, even though we're supposedly following the checklist. Okay? And then once we do shortcuts, usually you get away with it, no problems. No wrong side surgery. Okay, so what happens then really is that you migrate. That means it worked, I got away with it, so next time I'll do the same. Okay, so an example really is when you hand wash. You're supposed to hand wash every time you see a patient, before you see the next patient. But if you're very busy, you only hand wash when the patient's got MRSA, and that becomes norm for you. After a while, you only hand wash when you're being audited. And after a while, you don't hand wash. And when we investigate the wrong side surgery, it's the same thing. Initially, you take shortcuts, becomes norm. Okay, you get away with it. You shorten your workload, you end on time. And then next, you start doing that. And then one day, you have the wrong side surgery. Okay? This is a small study that we just published a few months ago, looking at how we actually do the checklist. Do we actually do a proper challenge and response? Okay. Now, during the timeout section of the checklist, what are you supposed to do? You're reading and you're doing the challenge response. What's the team supposed to do? Listen. Okay. But in real life, how often do you think you'll actually stop your work and listen? Okay. So what we find really is, as expected, we don't do it properly. We get a lot of distractions. We do a lot of different things during timeout. We're not engaged. And then there are many different types of distractions. From auditory, for example, phones, to irrelevant communication. That means we're talking to you about other things apart from the patient. Okay? Can we play? So what I want you to do is just have a look at the distractions. And the engagement during this timeout checklist. This is a real life checklist. Can we play the video, please? Yeah.
Okay, is everyone ready for timeout?
Yes.
Check the patient's wristband.
Yeah. On the left.
Get them on the table. Yes. Yep. The first is in for February 1972. Yep. Hospital number and then 091 4752. Yes. Lovely. So she's consented for count floor.
So what you can see really is that on average, probably out of 10 people, 2 people are engaged. The rest are, it's true, the rest are doing their own thing. So in real life, we should be stopping. We should do what we call sterile cockpit. Okay, sterile cockpit means in flights, when you're taking off, everybody is focused. No distractions, but we don't do that. Okay? So a few years ago, the CQC, or Clinical Quality Commission, that's our regulator, were very concerned because the number of wrong site surgery has not gone down. Okay? It's remained same, around 40 odd cases, and they were very concerned. So they went to all the experts in safety. They went to British Airways, they went to the Army, they went to the maritime industry. They actually came to our hospital because we work quite a bit with British Airways, and they also interviewed the patients. It's very interesting. They interviewed the patients who had wrong site surgery. And these are what the patients said. There were a lot of interruptions. Even though the checklist was done, people didn't pay much attention. Okay? There were a lot of interruptions. You can see the workload. They were doing too many cases. Okay? And then team was not engaged. Everybody was doing their own thing. All right? Okay. Now let me tell you what happened to me about in May last year. So we do outpatient Botox and incontinence. Botox and Vulcamate, sorry, for incontinence. So we do it in the outpatient setting. And the patients are awake. Okay, so there should be 0 wrong site surgery. Okay, so this is my list. Okay, and in our hospital, the patients are very few Caucasian people, so they're all from Spain, from other countries, and the names are quite difficult to pronounce. So one day, this day, I was very busy. We didn't have enough scopes. We had to go and get it. So I should already be aware this is dangerous. Okay, but I took shortcuts. So what I did really is, instead of remembering the names, I just said, okay, Vulcamate, 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 Botox. Easy. Okay? And we consented the patient, awake. Okay? The patient is for Botox. Then I had to go to get some scopes. And my nurse changed the order of the list because this Botox lady had to go home to collect the child from school. Changed the order, okay? And then we called so we did Vulcamate, called this patient in, and did put Vulcamate in the Botox patient. So we injected Vulcamate, whereas she's supposed to have Botox, and we did the checklist. And she went home. And then, for the last patient, there was no more Vulcamate. So we realized we gave the wrong thing. Yeah? What do you think went through my mind? Oh my God, is one. What went through my mind really is that, do I need to report this? Because human nature is you're scared. I made a mistake. Okay? Well, I phoned the patient up and she said she was fine. So thankfully, this patient both stress and urge incontinence. Okay? But her urge was worse. So we were supposed to give her Botox first. But she said, my stress is better now. So in a way, I got away with it. But it showed how easy it is to make mistakes. All right? And one of the reasons is because there was confirmation bias. That means the nurse asked the patient, awake, you're having Botox, aren't you? Or you're having Vulcamate, aren't you? The patient said, yes. Instead of us doing independent checking and reading it properly. So we did the work as imagined versus work as done. We took shortcuts and we made an error. Okay? Thankfully, there's no harm. But it could have gone really, really badly. Okay? So we'll go on to retained swabs now. Have you had any retained swabs in your practice? You have many. Okay. Do you think it will go down? Do you think we can eliminate it? Very good. So many people now are thinking that retained swabs cannot be eliminated. Okay? So when I go and speak to my colleagues in the pilots, I often ask them, do you tell them that you have zero harm where there's no crashes? No crashes of aeroplanes at all. And what they say really is that, no, we cannot promise that. We cannot guarantee there's zero harm because it will not happen. But what we promise really is that we will minimize it so that you fly as safely as you can. And many people believe the same. Retained swabs are probably not eliminated. And there's talk that they will take this off from the never events list. Okay? So this is a typical sort of typical report from retained swabs. And they say the same thing. There's distractions, you're doing too many things, you're rushing to go home. More lessons learned. Okay? So, now the human factors people, there are many different types. So some of them are involved in healthcare, like myself. Some of them are involved in design. Okay? So they will then investigate this retained swab and they will come up with a report. Okay? So they say, interestingly, they say we can actually reduce to zero. No retained swabs. How do you think we can do that? So this is what they say. This is called the hierarchy of intervention. So what they say, we don't use. Okay, it's come back. Thank you. So these human factors people, they are basically designing things rather than doctors or nurses. So what they say really is that don't use tampons, don't use swabs. And what we do, what we do is basically down here, okay? Checking, cross-checking, making sure there's communication. And what they say really is unreliable. Best thing is don't use swabs, but that's not practical in our specialty. Okay? So really, probably retained swabs are not possible to remove. I'll just do one more case. This is actually quite interesting because in the afternoon you'll be doing packing. About a year ago, I was called to help my colleague who was doing a laparoscopic hysterectomy and then started bleeding. And then she had to convert to an open hysterectomy. Okay? So we really couldn't stop the bleeding. It took a couple of hours, and then we thought we'd pack her. So we put packs in to actually stop all the venous ooze. And we put in 7 packs. So we corrected the coagulation. Next day, we took her back to theater. And together with the nurses, we took out the packs. 1, 2, 3, 4, 5, 6, 7. And then to our surprise, there was actually an 8th pack inside. We put in 7, but 8 came out. Okay? So what actually happened? Counting was wrong. Okay. So yeah, you're right. So this is what we do. We pack it. And you're right. What we lost really is the sterile cockpit. So when we're counting, I remember it clearly, someone interrupted me. Okay, someone came in with blood, interrupted me. And then I remember asking the nurse, was it the 5th swab or the 6th swab? Was it the 5th? She said, yes. What I should have done was, what number swab was that? Okay, so that's confirmation bias. She just said yes, so we thought it's the same. And then we took an extra swab out. What happens next when you put in 7 swabs and 8 came out? What would you do? Well, you definitely report, but what's next after that? What do you do? Sorry? Look for another pack. You're right, look for 9 packs. So the theater manager said we can't close. We need to get x-ray. Well, she said I counted same as you. We couldn't find out why. I think I was interrupted and I lost track. And then we had confirmation bias, different things, okay? So sterile cockpit, counting people, we get distracted quite easily. This is what we should do. Yeah, so what in the future, when I pack, what I do now really is that I will count with everyone. This is number 1, okay? Number 2, so we do something like this. Okay. So our final video, I just want you to listen carefully, okay? This is one of our doctors, and it's the concept really is cross-checking. You want to play the video? Thanks, thank you.
Dr. Das, would you mind just checking the drug with me, please?
Yeah, that's
fine. Just give me 2 seconds. I'm just finishing off signing an op note and I'll get back to you. Yeah? That's all right. Okay, fine. Okay.
So, do you mind just double checking it with me? So, would you read that?
Yes. So it's Botox, 100 units, botulinum toxin type A for IM and intradermal use. The expiry date is 03/2020, which is March 2020.
Brilliant. So, just to confirm.
So I'm sorry, it wasn't very clear. But what happened really was that the SHO was asking the registrar to cross-check a Botox. Okay? And the way to do it correctly really is independent cross-checking. That means he'll say to you, can you read this out for me? Okay? What we quite often we do really is we say, Shahrazad, this is Botox, isn't it? So that introduces bias. Okay? And you notice at the beginning, she was doing her notes, electronic notes. So when she was interrupted, rather than stopping the task, she said, stop, let me finish my notes, and then I'll cross-check with you. Okay? So in summary, what we advocate really is you probably can't stop wrong side surgery to 0. Same with retained swabs. What you can do is practice the cross-checking discipline. Always be vigilant. Okay? So to take home points, wrong side surgery and retained swabs will probably happen. And usually they are due to deviations from your protocol. Okay? Distractions and not managing your workload. You can deviate from your protocols. Pilots often say, this is our protocol. Okay? As a team, we make a decision to deviate because of certain things. But it must be justifiable. Okay? And then these can be minimized by maintaining a checking discipline. Okay, thank you very much. Thank you. Thanks.
Thank you very much, Dr. Vai, for such an excellent talk. Our next presentation is on developing effective teams. I request Dr. Wasim on the stage for his next presentation.
Okay, thank you for giving me the opportunity to talk again. And I'm sorry, I wasn't expecting. I thought there is another lecture before me. So this time we'll talk about team building. And I became interested in these leadership type things because I took up a CD post for my department. And I thought that I'm a horrible leader or a manager, so I can't manage anything. And I need to develop myself. So I started then looking into these things, and then I found a lot of things that could be improved. And the greatest one was that I could improve myself, and I thought it would be useful to learn from my learning, especially to the juniors. And because nobody teaches leadership as part of medical curriculum, and especially those of us who go from Pakistan, so zero leadership learning from here, at least in my time 30 years ago. So, do you agree with this statement? Who doesn't agree, or who agrees with this statement? Let's put it like that. So the context of that is you join a department and you say that, okay, you just train me for 3 years. You are very good trainee and all that, but I'm not going to stay with you. After 3 years, I need to go and set up my own private practice and be on the competition with the urogynecologists of Shalimar Hospital. So do you think Dr. Nazli will say to her, I'm going to train you because tomorrow you will come and you will be sitting next to me in a private clinic? In a nutshell, that's how you would look at it. So the thing is, a lot of time when you go into an organization and if you tell them, I'm going to leave, people will not be interested in training you. And this is where we need to change that mindset, because if you stay there for those 3 years and you know these people are not giving me the opportunity to flourish, to shine, you will have zero interest in that organization. You will be thinking, okay, they are not investing in me, why should I invest in that organization? So essentially, it's the failure for that organization. Sorry, I'd say sometimes politically incorrect things, so please ignore them. Now, when I did this talk first time, I did it for ST12 trainees in Birmingham Deanery, and I asked them this question, why do you think I'm doing this talk? And these two answers, they were very interesting. Here it says, because it is on the timetable, and second one, it says, tick box exercise. So you can imagine the thought process behind that person who is there, and that person, I don't know, he or she, is an ST1 or 2 trainee. So we shouldn't be looking at it this way. I think we should look at it that it is going to develop us, and then that will help us in developing the organization you are working for, and professionally as well. Right. So first of all, what is a team? And what is a group? So what is team? Okay. Okay, so you are saying it's like what I'm hearing here is leader, roles. Now the thing is that if I say, all of you sitting here, are you a team or you are a group? You are a group. Exactly. The teams, they have a common goal. So if I say that Dr. Nazli had a team who organized this summit, so I will not say Dr. Nazli had a group who organized this summit. So Dr. Nazli had a team, so they organized this this summit because they were all working towards a common goal, which was to have a successful summit and an interesting summit for everybody. So that is a team. They are all working together, a common goal. However, all of you who are here, you are coming here as Ops and Gynae group. So you are all working in this specialty. So you have come here, you are a group, but if you embrace this idea that I am here because I am going to work towards improvement of maternal safety, I will work towards the improvement of changing the culture, then you become a team with Professor Nazli. So isn't it? So you are all a group, but you have to then think that what is she thinking, what is her vision, and then collectively you have that. I know it's difficult because we all have different thoughts and we don't think this person is thinking right, but then end of the day, that's the nutshell. Right, so a team is a group of individuals all working together for a common purpose. And then a group can be individuals with these varied interests and attitudes. So why effective teams matter? I want you to take out your phone. A lot of you will be having phone in your hands already. So if you scan this QR code with your camera, it will bring up this slide onto your screen. And then if you just type, what word comes to your mind that why effective teams matter? Let's see if it works. Yeah, good. A tech-savvy person has already typed it. So. To get to the goal, I believe, not the whole, isn't it? Okay, good. So you all have those sort of thoughts. So essentially, there is something working together. That's the nutshell of this whole, to achieve the goal, to have better outcomes. Okay, that's fine. You can stop it now. I will move on to the next slide. So okay, right. So this was, if you look at it, this was from the ST12 training group. So they were juniors, just starting the training in specialty, and that's how they thought. And then if you compare it with yours one, so it's more or less similar. There are things which are common. Right, so why then do the effective teams, they matter? They matter because if you have the right team, when you invest in them, they would work smarter. They don't have to work harder. And that would increase the productivity for the department. And then, when you have diversity in the team, you don't have to have all the people who are going to agree with you. You need to have people who need to have some conflict. They can say, I don't agree with you, because if everybody is yes ma'am, yes sir, it's not going to be really beneficial for the team. So when you have that, people will have different ideas, and that then helps in having innovation in the department, because you would come up with different ideas as well. And then with all those different minds working together, you will be able to achieve results, because you will be able to solve complex problems, because more brains are better than one brain. And then not only that, because people will be working together and they will be happy, and I refer to the slide in the morning that happier people are less prone to making mistakes, so that would boost the morale of the department. And as a result of that, your patients would get better customer care. Do you agree with this slide? Okay, so now another exercise. If you were slow last time, so this time be quick. So what are the cornerstones of effective teams? What do you think we need to be an effective team member? So what is 1913417? Leadership, energy, dedication. Harmony. There is one word which is still missing. We haven't said yes, no, it is there. The most important thing that you need, which is the cornerstone of effective teams, is this. Can you see that? What is the single most one? Trust. Here. So that is the basic fundamental of the pillar of team working. Now, everything starts with trust. See this video, and then it would tell you what are the 5 cornerstones of the treatment. And when you are listening to this video, this is Peter Lenconi. He's a psychologist, and he gave this talk. It's on YouTube. Very, very, very nice talk, actually. And reflect on wherever you are working. And if you think that, I remember that when I was in training in Pakistan, so we used to hear that this department, say in Lady Wellington, or this department in Jinnah Hospital is good, that is not good. I'm just referring to the names. It doesn't matter. I have never worked there, don't know any of the people, so please don't take it personally. But it's just one of those things that some departments, they are better functioning, they are nice to work, everybody wants to go there, and there are certain departments where nobody wants to work. And why is that? And the answer is here. Video is audio kar de. आई थिंक इसको छोड़ दें, आप मेरी दूसरी प्रेजेंटेशन वहाँ से खोल लें. I think that's the problem with technology. So you don't trust it, isn't it? That's the first thing. It comes with the trust. So essentially, the first thing is trust. What happens is that when you have trust, in each other, you are able to share your ideas more openly. Even if you are not saying something right, or you will not have the fear of repercussion that the other person will think, I do not think in the right way, or anything like that. So with trust, you are more open. You are able to collaborate with your teams better, and you are able to share your ideas better as well. Dekhein play hoti hai?
When it comes to creating a healthy organization, the first and most important discipline is the building of a cohesive leadership team at the top. And that entails the overcoming of the 5 dysfunctions of a team, which I'm going to review very quickly here. The first dysfunction of a team is the absence of trust. Trust is critical on a team. It's the foundation of teamwork. And what it requires is that people get vulnerable with one another, that they're very open about who they are, what they're good at, what they're not good at, if they've made a mistake. Without trust, we cannot build a team. Specifically because without trust, we can't overcome the second dysfunction, which is the fear of conflict. You see, conflict is not only okay on a team, or even good, it's necessary and required. We have to engage in conflict, and when we have trust, conflict becomes nothing but the passionate pursuit of truth or the best possible answer. Why is conflict so important? Because without it, we're going to encounter the third dysfunction of a team, which is the lack of commitment. Teams that don't engage in open, honest conflict don't really commit to the decisions they make. They're passive about it. Commitment is when everybody truly buys in because they've weighed in on a decision and they realize that's what they're all going to stick with. Now, why is commitment so important? Because without it, we're going to encounter the fourth and most common dysfunction of a team, which is the inability of people to hold each other accountable. Accountability is so important on a team. When people have committed, they're going to have more courage to actually confront one another about shortcomings in their behavior and their performance. And why is that accountability so important? Because if people aren't holding each other accountable, they're going to encounter the next and final dysfunction, which is the inattention to results. Now, you might say, well, what are people paying attention to if not results? Well, maybe it's not the collective results of the team they're interested in, but just their own individual results, their budget, their department, their staff. If we're going to focus on the collective results of the team, we have to trust one another, we have to engage in healthy conflict, we have to commit to decisions, hold one another accountable for those, and achieve true collective results. Those are the 5 dysfunctions of a team.
Do you think it makes sense? It's just like you become prime minister or you become chief minister, so you want to have your own team of ministers, secretaries, and all those things. And they make a big difference because although people may not like that idea sometimes, people would think, why are you having these? Because you like these people. It is not because of that. When I became clinical director for my department, so I decided to have my deputy clinical director, Shahzad was my deputy clinical director, and the college tutors, I pushed 2 of my other colleagues to go into those roles. And some people, there was a big uproar actually. They felt that, no, this is unfair, I'm not giving anybody else an opportunity. But then, end of the day, if I have to be successful, I need to have a team which thinks with me and for me, and which will be able to correct me if I am wrong, and I feel comfortable taking their advice, guidance, criticism as well. And that's how then, like, I've got Shahzad, and this is our photo from last year. So Vai used to be my consultant when I was his trainee, Shahzad used to be my trainee, and I was her consultant. But then we reached a point, if I have any issue, I will be happy to share it with her, and she will not hesitate criticizing me even when I was a CD. And I would just take it and then carry on with that. So that's why you need to have a team together. So how do you build great teams? So basically, team building is like a dream exercise. It's just like when you decide you are going to get married, you want to go and get investigations about that family because you are going to spend time with that family and you want to know everything about them. Because end of the day, it is going to bring harmony to your house, it is going to bring harmony to your family. And you want to select the right people. There is no point having somebody who is clinically excellent. Say you get a very good surgeon who is extremely arrogant, who doesn't talk to anybody, has got zero humbleness, how are you going to work with that person? Because if that person has got zero communication skills, so his excellent surgical skills are pointless for you. Because it will be like a one-man show. He will go, he will operate, anybody else is doing anything, and he will say, this is all crap, this is all crap. They don't know how to operate. I'm the one who knows all that. So that is the important thing. Then the other thing is fostering diversity. You don't want to have people of the same type in your team. As I mentioned early on, you want to have diversity because people from different cultural, ethnic backgrounds, different education backgrounds, they bring in new ideas. And then when you have those ideas, it will change basically the dynamics of your team, and you will be able to achieve far more. And then also, whenever you are building your team, you need to establish roles and responsibilities. As somebody said from here in my first slide, that team, you give them roles. But when you give them roles, you need to specify that, okay, you are the event coordinator for this, so your role is you are going to look for, say, catering. So you provide good food to people. And without good food, nobody comes to the events these days, isn't it? You need to have food, no? Yeah. So it's important to have those roles and responsibilities. It doesn't matter whether you are the junior-most trainee or the person in the department who has been given a role. If you stick to your role and you are accountable for that, you will be able to do a better job. And I'm just almost near the end. So this is another excellent video. This guy is Simon Sinek. Anybody has seen him? He has got a lot of leadership videos on YouTube. And if you listen to him, it's fantastic. It would just, in a nutshell, whatever you need in a team, it's there.
Plus, I just think this is really interesting. So I've worked with the Navy SEALs. And I asked them, like, how do you pick like the guys that go on SEAL Team 6? Right? Because they're the best, the best, the best, the best. And they drew a graph for me. And on one side, they wrote the word performance, and on the other side, they wrote the word trust. The way they define the terms is performance on the battlefield and performance off the battlefield. So this is your skills, did you make your quarterly earnings, however you want to translate it, right? Performance, it's traditional. This is, how are you off the battlefield? What kind of person are you? The way they put it is, I may trust you with my life, but do I trust you with my money and my wife? They're SEALs. This is what they told me. Nobody wants this person, the low performer of low trust, of course. Of course, everybody wants this person, the high performer of high trust, of course. What they learned is that this person, the high performer of low trust, is a toxic leader and a toxic team member. And they would rather have a medium performer of high trust, sometimes even a low performer of high trust, it's a relative scale, over this person.
Do you agree with that? So that's the purpose, that you don't just go for one aspect. You have to look at the balanced aspect. So I'm just going to skip a couple of things and move forward. I'm already over my time. So basically, communication is the key. And you should be able to communicate with their team. It's no point having a team and not communicating with them. And it should be bi-directional communication rather than one-sided. And I would just skip that. So basically, this session was to stimulate your mind to these leadership qualities. I mean, today you are a trainee, or you may be a trainee or a medical student. Tomorrow you are going to become a consultant, and you will be climbing up the leadership ladder. And I think these things, they should help. And this is just the very last one, if you give me 1 minute. So it's something very interesting. Think on this video, and then visualize what you are thinking. Later when we have the Q&A session, you can tell me what you thought of this.
Woo! Dr. Zoidberg. Hooray for Dr. Zoidberg.
There you go. The way I look at it is that you are somebody new in a department, and then when you go in, people are a bit concerned and they don't like you, everybody's watching you closely. Then as you get in, you may bring the team together, but there will always be some elements which are trying to get rid of you, and then they start doing all that, and then sometimes that exposes the department. Thank you very much. So I will just finish off here.
I would like to invite Dr. Wasim Lodi for his next talk on which uterine compression suture should be used in uterine atony.
Change of flavor. So we had enough of human factors. So we'll move on to more of the technical skills. So this is essentially just setting the scene for the afternoon workshops as well. So uterine compression sutures, which one to use? So they have been going on for a long time. There are different techniques. We have been running different courses, the PPH management workshops at the college from 2012. As I mentioned this morning, we started from Malaysia, one of the RCOG conferences, and then it became quite a regular sort of event. Now, it has been very popular, and one of the things that it's not one-sided learning, that people come to learn from it, so we learn from other people's experiences as facilitators as well. So people come in, they come with different ideas, I do this, I do that, and it has worked for me. Then it becomes very difficult to justify whether they are doing it right, they are doing it wrong. End of the day, they manage to save the uterus of the woman. So it doesn't matter. So whatever you need to do, remember the golden hour, do it as soon as possible. And it's useful to learn uterine compression sutures so that you can apply it sooner rather than later. And it is also useful to have juniors train into that they don't have to wait for a senior registrar to come in or a consultant to come in to do the compression suture. So these are some of the courses that we have run for the PPH management workshop. The list goes on, and we have a lot of successful ones, and people learned a lot from that. So B-Lynch uterine compression sutures is considered as the gold standard. Is everybody in agreement with that? So are you aware of any other? So you know where I am standing, all I can hear is, I can't hear anything. So I hope you were saying Heyman suture. So one person at a time, loud and clear, then it will make sense. Then, so the B-Lynch uterine compression suture was introduced in 1997 by Professor B-Lynch, and they then published a paper. This was their original paper, and in which they described the technique of that, and then how successful it was. It was a series of some of the cases. So after this, because if you look at it, it's still a bit complicated. There are different steps involved with that you start from here, you go over, and all that. One thing which I would ask you to remember is this, the bottom one, this diagram, okay? So those 3 centimeters margins, they are very useful. So the reason I'm saying is while we are on this slide, it will save a couple of seconds or minutes for the next session this afternoon. So 3 centimeters above, 3 centimeters below, 3 centimeters lateral. So that was his original paper. Then after that, what happened was that Richard Heyman, he wrote up this paper and described this Heyman's uterine compression suture. Now there was a very interesting story to that Prof. Arul, who was the previous RCOG president, he told that he is one of the co-authors of this paper. He was on call and Richard Heyman used to be their clinical fellow. So one night when Richard was on call and one night when Prof. Arul was on call, so he called Prof. Arul because there was a patient who was having massive PPH and they needed to apply the compression suture. By that time, Professor B. Lynch suture was already published and people knew about it. Now these people, they tried to remember the steps of B. Lynch compression suture, but they couldn't remember. Then they thought that end of the day, we have to apply 2 vertical compression sutures. So they did that, and that worked very well for this patient. So essentially, if you look at it, these are 2 vertical compression sutures which are compressing the body of the uterus. The lower ones are just the horizontal ones, just to, if the placenta is low-lying. So this worked very well as well, and they published this paper in somewhere in 2000, I think, 2002. So after this, then a lot of people, they started different sort of techniques. One of them was modified B. Lynch compression suture. So I was a trainee at that time, and one of our patients who had uterine atony after vaginal delivery needed to go back to theater for an EUA. And then because Beckery balloon had failed, so my consultant at that time, she decided let's do a laparotomy, and she put in compression suture, which was a modified uterine compression suture. As you heard from Y before about hierarchy and authority gradient, so I was a trainee and I was I think not long in UK. So as a result of that, I couldn't question my consultant that why are you doing this and whether it is right or wrong. So essentially what she did was, her argument was this woman had a normal delivery. We have done an EUA, explored the cavity of the uterus. We have tried Beckery balloon. It has not worked. So we do not need to open up the uterine cavity when we do the B. Lynch compression suture. So what she did was that she took the bites on the front, but when she went towards the back, she didn't go back into the uterine cavity as you do for a normal B. Lynch compression suture. Instead, she took just a big bite from the posterior surface of the uterus and came to the other side. So this woman, all went well, bleeding stopped, woman went home. I saw her 2-3 times because interestingly, whenever she came in, I was on call, and she came initially with foul-smelling discharge. And we gave her antibiotics, again came back because she was diabetic as well. And then after a couple of days when she came back, when I did a speculum, I think on day 18 or 19, I couldn't see anything in the vagina. There was like a mass sitting over there on speculum. So I tried to do a VE and I felt there was some big mass over there. So I spoke to my consultant, and then the decision was, let's take her to theater for because we did an MRI as well, and that was showing gas in the uterine cavity. So the diagnosis wasn't very clear what was going on. Is it gangrene happening or something else? So anyhow, when my consultant started doing the laparoscopy first, so she saw this hole, as in the first figure. It's around the fundus of the region. And I was at the vaginal end. As I cleaned the vagina and took out my swab, this thing came out. Now, I wasn't sure what exactly is that. And then I pulled it out. It came out. It was still attached inside. And my consultant was seeing this thing right from the top. So as I pulled on this mass, this thing all came in my hand. And that's how it was. It was cervix and then this mass. So essentially, what we then discovered was that whole of the myometrium had separated from the serosa. So this serosa here was just standing there, but there was nothing inside. All the muscle had come from below. It's just like the whole thing has been enucleated, basically. So I published this initially in one of the RCOG conferences, and Professor B. Lynch came up. It was in 2007 in, I think, Vancouver. He came in and then he looked at it and he said, oh, this person doesn't know how to do the B. Lynch suture. Again, I was an Asian trainee at that time, hierarchy, authority gradient. I couldn't question him, why and all that. So later, Professor B. Lynch started teaching on these PPH courses with us. And then I had developed more courage by that time and had undergone some transformation subsequent to my UK experience. Then I asked him the same question, that why do you think it's like that? And his argument was that because they didn't open up the uterine cavity, so it is not a proper B. Lynch suture. And he is very particular about that. I mean, he's quite old and frail and unwell now, but and he still had this sort of argument. So this sort of thing can happen, the uterine necrosis. It has been described in literature. Professor B. Lynch's argument was that you can have no complications if you apply B. Lynch suture properly. But if you read the reports, a lot of people, they had uterine necrosis, which is the commonest one. Then another thing which came up is that if you are applying any sort of uterine compression suture, you can still use a balloon tamponade as well, because what it would do is it would compress the uterus from inside, and then the compression suture would compress from the outside. As a result of that, you would be able to put a better pressure on the uterus. And again, it is not something which is dangerous or it's unusual, it's pretty common. And at least in our unit, if we have to do that, sometimes the placental bed is bleeding. So you find it easier to put it because you can remove the balloon after 12 hours or so. And that's one of the papers that I published about the same. And it's a very successful technique. And if you do it in early stages, it saves a lot of hysterectomies. So then when people started describing their own techniques, this was one of that. It's from Pereira. What they did essentially here, if you look here, they have taken these horizontal sutures on the uterus, and then they took two longitudinal sutures, tied them to the lowest horizontal one, and then to the highest horizontal one by looping over the fundus of the uterus. So essentially what you are trying to do is, you are trying to compress the uterus, something like that. Okay, so they published this paper and they said we have done so many cases, they have been successful, and we saved the uterus. Then this team published another paper. What they did was that they applied these compression sutures from front to back, basically, and then that's how it was looking. And again, it was essentially compressing the sutures. Now, one of the arguments that people can have with this is that if you're applying horizontal sutures, the blood will not be able to drain. As a result of that, you may end up having a collection of blood or pus inside. However, because the sutures are dissolvable, so they work okay. Then Heckenthal, they published this paper, and what they did essentially the same like Ohba paper, the one before. They applied multiple horizontal sutures, something like that. So essentially what they are trying is, again, is to compress the anterior and the posterior walls of the uterus and expecting it to stop the bleeding. So it worked well for them as well. Then I found this article which was published about the long-term efficacy of Hayman suture. Everybody is very familiar with B. Lynch suture, but not many people, they know about the efficacy of Hayman suture. Even when I started teaching on the RCOG PPH conferences, a lot of people, they used to think as if Hayman's is like I have invented. I had absolutely no idea what it was. And actually, Prof. Arul told us that Hayman was his clinical fellow, and he said we told him to write up the paper. So he wrote up the paper and he took up the name. And Prof. Arul, if you have met him, he's a very humble person, and he didn't claim all the glory for that. And he let Richard take up the credit for that. And interestingly, Richard Heyman, he doesn't practice obstetrics. He's a private gynecologist now. So this paper from India, they looked at the long-term efficacy of uterine compression sutures, particularly Heyman's. And they found that this was quite actually effective. A lot of patients, it's not just that you are saving the uterus. What matters is that in the long term, if this woman wants to become pregnant again, will it work or not? And they found, whatever studies or case reports had been published, that this is an effective sort of management options outside B-Lynch. So this could be your first line management because it's much easier to perform, and this afternoon we will practice all that on the hands-on station. Then from China, 2 reports came up. So this was also, what they did was that they took up a suture, just like a stitch on the myometrium anteriorly, looped over the uterus, went back, and then they tied the knot on the fundus of the uterus. Now essentially, if you look at it, the process is very similar to Heyman's suture, but they have not gone through and through the uterus because their argument was that we are trying to compress the uterus. And it worked for their case series as well when they published this paper. That's how it was looking. Then another paper came up from China as well with the team. What they did was that they started the suture from inside the uterus. And then after they had completed, they pushed the knot, which was tied inside, into the vagina, just like coil threads basically. And after about 24 hours, they used a coil retriever hook and long scissors to cut that thread and then remove that, because by that time the blood clot would have worked and then the uterus would remain well contracted. And they claimed that this has also worked very well. But still, if you look at it, the technique is still more or less like Heyman's. You are going from the top and then compressing it. Then this one came from Morocco. So this looks quite horrible if you look at it, isn't it? So what they did was that they essentially compressed the uterus against the pubic symphysis. So as you know that in Middle Eastern countries, uterus is of great value, and women, they want to retain it as much as possible. So this was a multiparous patient where they then decided to do that, and essentially they brought the sutures out on the abdominal wall. So the patient was intubated and then the uterus was essentially compressed against the pubic symphysis. They were able to save the uterus. They performed it on a couple of patients, and I think 4 or 5, and they said 1 patient died, and that was not because of infection or any other complication, but it was because of CVA, stroke basically. Now, again, this sort of thing, it seems a bit more radical, and that reminds me that one of my colleagues, she told me that she was working in Saudi Arabia, and they had a patient who came for her 5th or 6th cesarean section, and she had placenta accreta, which was invading the bladder as well. They tried to explain it to the husband, because as you know, in Middle Eastern culture, husband is the one who is giving consent for everything. So they tried to explain to the husband that she needs to have a hysterectomy because of the placenta accreta. The husband, who couldn't understand that, and what he said was, why don't you remove the bladder if it is invading and leave the uterus behind? So that's how some people they think. G? Okay. And then this suture also came up from Japan. And then another one came up. Again, if you look at it, it's both just following the same sort of principle of Heyman's suture. Another one similar to that. Another one similar to that. So if you look at all these sutures, I mean the previous ones, they are just following essentially the framework of Heyman's suture, that you are putting 2 longitudinal sutures. Cho suture was slightly different, that essentially what they are creating is small pockets, essentially compressing the anterior and the posterior uterine wall. And then end of the day, whatever type of suture you are doing, so what it is doing is that it is just compressing the uterus. This report came up from Thailand, and what they did was they actually folded the uterus. It's like completely just like that, and compressed it. Now, when you have few cases, it's very difficult to say what is the long-term efficacy of that, because you would preserve the uterus, but you don't know whether this woman will ever be able to become pregnant or not. That's how it looked at the end. So this was another one, looks quite radical. Nausicaa is actually a mythical creature in Japanese culture, and that's this green thing, number D1. That's how it looks like. So they applied these multiple horizontal sutures, and again, they managed to save the uterus, but what was the benefit of that? We don't know in the long run. This is one of the recent ones which was there, so it's just essentially horizontal ones. So essentially, whatever sutures you are using, so these are different reports. Everybody is claiming it's equally effective. So it doesn't matter what type of suture you use or what type of technique you use. They are all following either the B-Lynch technique or the Heyman's technique. Then you can modify it whatever way you like, and then it all depends on your own circumstances. It's not that one is superior to the other. You have to look at it, what is easier to perform, quicker to perform, better for the patient as well. And then in order to perform these, you need to practice as well. So you cannot just come one day and then perform it, because you may do 1 or 2 uterine compression sutures in a year. So you can develop your own models. This afternoon you will see we will be using uteruses made up of stockings and polyester fiber from your old pillows. And you can develop similar sort of things and do at home, practice at home. So in conclusion, the subsequent pregnancy outcomes for all of them, they were very similar. We don't know which one worked better because we don't have long-term data for that. And end of the day, what mattered was how soon you applied the compression suture. Remember the golden hour, use the technique that you are more comfortable with, you have practiced at home, and then hopefully you should be able to help that woman in conserving her uterus. And both are equally effective. Do not think, please do not think, I'm emphasizing again and again, a lot of people, they are just like, for some reason, think B-Lynch is the suture, B-Lynch is the suture, Heyman is equally effective. And learn the technique for that. And then you can teach it to your residents as well, because it's quicker to grasp as well. And then whatever type of suture you use, its viability basically then depends whether this woman is able to survive, to keep the uterus, but then in future have another pregnancy. Any questions, anything? Want to ask? Oh, we'll ask later, isn't it? Yeah. Okay, sorry, I just have to rush, otherwise you will not get lunch today. Thank you.
Thank you very much, Dr. Wasim, Dr. Scheherazade, and Dr. Wai Yong for the next presentation on why juniors don't speak up.
So thank you very much. We hope you enjoyed our sort of taster workshop, we call it. Okay, so the next presentation really is called Why Juniors Don't Challenge Seniors, okay, or Understanding Authority Gradient. So we gave this talk actually in Figo in Paris last year, the year before, okay, and people liked it. So Scheherazade and I will be co-presenting. So a few years ago, the Each Baby Counts report was instituted, and what they found was that quite often errors are due to either loss of helicopter view or failure of escalation. And why do people fail to escalate? Usually it's because trainees find it difficult to speak up. They find it difficult to challenge seniors. And actually nowadays, we don't use the word challenge. You don't have to challenge your seniors. We call it information sharing. Okay, sharing information that your senior may not have seen. So this article basically is about how you actually, what tools you need and what seniors need to do. Okay, so we'll be covering all these aspects. So when you break down hierarchy or authority gradient, these are the different aspects. So you've got power distance index, you've got mitigation, how to challenge without being aggressive. Should you call your boss by the first name? Okay, and then active listening, empowering patients, and then lastly, just culture.
Okay, so can I ask you what is the difference between authority gradient and hierarchy? Is it the same thing? Is it different? Is it slightly different? What is the difference? Anyone? Okay. Yeah. So.
Do you want to repeat what she said?
Yeah, so hierarchy, like it's.
No, for the audience.
For the yeah. So it is what you've just explained. So if I give you an example, I'm going back to London over the weekend, and I'm on call on Monday. So during the on-call, I'll be the registrar, not the registrar, I'm the consultant, by the way. Consultant on-call, I'll have a registrar, I have the SHO, and maybe a medical student. This is hierarchy, okay? But if I'm smart enough, I will make that authority gradient steep, shallow, so I will allow people to speak up when I'm on call. They can approach me for any question. They can challenge my decision. Well, challenge is not the right word, but they can approach me with any issue they want to discuss. So this is the difference between authority gradient and hierarchy. We're going to watch a video, and I'm going to ask you questions. Okay, so take time to watch this, and then we'll come back.
Could we play the video?
Please.
Morning, Sir Lancelot. Good morning. Morning, gentlemen. Good morning, sir. Not late, I hope? Not at all, sir. Come along, my man. You must pursue me. You must pursue me. I suppose you got another half-dozen boring cholecystectomies today? Yes, sir. After last night, I feel like one myself. How about that gastrectomy I did yesterday? Not so well, sir. Oh, pity. Great pity. Morning, sister.
Morning, Sir Lancelot.
Everything ready?
All ready, sir.
Splendid. Now, you just lie still, old fellow. I'm just going to discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked? Yes, sir. See anything? No, sir. Very good, carry on. Gently, man, gently, you're not making bread. Don't forget, to be a successful surgeon, you need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it? Yes, sir. Well, what is it? A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. And where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. Now, don't worry. This is nothing whatever to do with you.
Okay, so what is the authority gradient here? Is it high or is it shallow?
Steep, yes.
Hmm?
Yep, steep, yes.
Okay, and what about the hierarchy? We can see. And final question. Is it like that in your units? Has it been like that and it's changing? I trained in Algeria years back and it was like that. Now I don't know if it has changed, but it used to be like that. Still, I'm not saying anything there.
Okay, so pilots recognize this. Okay, so in the cockpit, they say there's always going to be hierarchy because it has to be accountable. There has to be a captain. The same way there has to be a senior consultant, always going to be hierarchy. But the smart pilot really says we need to make the work environment shallow, okay, not steep, not flat, If it's flat, there's no authority. But shallow, so that people can speak up. So typically, in the cockpit, you've got a captain and the first officer. And the way they're trained really is that the first officer must always challenge if they see something wrong. So every 6 months, they will do revalidation. And one of the tests they do really is that in the test, someone will make a mistake. And if you don't speak up, you'll fail. Okay? So they're trained and people expect that. So nowadays, so look at this now. So here basically is a video we made for the Human Factors workshop at the college last year. And here's Shahzad talking to a trainee. And see what you think about the authority gradient here. Okay, do you want to play the video?
Cesarean section. And when we started operating, she started bleeding really from the start. And when I delivered the baby, I realized there was bilateral angle extensions as well. And the bleeding was really heavy. So I was trying to do sutures, trying anything to stop the bleeding. And I guess I lost track of what was going on because all of a sudden I was told by one of the theatre team that she'd lost 2.5 litres. And at that point I realized.
So you can see, you may not hear very well, but you can sense from the tone, there's no raised tones, there's eye contact, okay? So this is the sort of shallow authority gradient nowadays that we actually encourage. Yeah, you see your consultant as an advisor. If you see something wrong, you can escalate without fear of being repercussions.
Cesareans.
Okay, so one of the things we talk about really is something called power distance index. Okay, power distance index. And it's a term that's actually designed by someone called Hofstede from the Netherlands. What's the most dangerous airline in the world? So, what? Okay, I go the other way around. What's the world's safest airline? Never crash. Sorry? Emirates, no. Okay, it's actually Qantas. Okay, the reason I say this is because when I was training, and certainly when Rani was training, we used to have a lot of Australian trainees coming from Australia as an exchange program. And we always used to think these people are troublemakers. And now when we look back, it's not that they're troublemakers, but they are happy to speak up. Yeah, in Australia, people speak up. In Israel, people speak up. All right? So Hofstede looked at plane crashes. He listened to the black boxes of the plane crashes. And what he found really was that quite often, the first officer, the registrar, so to speak, will be saying something, all right? And the captain will ignore it, and that's why they crash, okay? The most dangerous airline up to about 15 years ago is actually South Korean Airlines, because they had a very, very steep hierarchy, very, very steep authority gradient, and the captain just didn't listen. So they found that they crashed a lot. They had to bring in a new team. They had to retrain in human factors, and now it's safe. Okay? So this is actually very interesting. Hofstede then projected his power distance index worldwide. Okay? So he looked in your country, how hierarchical or steep is the culture. So where I come from Malaysia, somewhere there, it's very steep. Okay? Whatever your boss says, you have to do. Okay? And then you've got places like Australia, where it's very shallow. The boss and the worker, there's not that much difference. But they know who's boss. There's accountability. And then you've got America, you've got Europe, and then you've got India and Pakistan. Okay? Why is this relevant? Because to us in London, a typical team in theatre is like this. Yeah, so I cannot extrapolate to here because here you're quite uniform. You're all from the same culture. You probably do the same things, share the same mental model. But in places like America or London or Liverpool, in big cities, you have people coming from different cultures. And they all have different things. Okay? The Spanish people may speak quite well. They're not afraid of raising concerns. Someone from Philippines will never speak up. Okay? So Hofstede also looked at this collectivism versus individualism. So some cultures, they're very happy to speak up. Yeah. For example, UK, Australia, Israelis, they just speak up. Other countries, where I come from, Malaysia, Singapore, they will never speak up. They want to be collective. Nobody wants to stand out. And it's quite important that we recognize that. Okay. Yeah.
Okay, so we're going to look at mitigated speech. So the way we talk to each other, the way we want to escalate, we need to be clear on what we are going to say. Yeah, next slide. So there are we are all different from when it comes to where we come from. And if I tell why.
Okay. Yes.
It's been a while since we had something to drink. What I'm trying to tell you why here.
Okay. So this just means that quite often in different cultures, like my culture and her culture, we don't say direct things. Okay, if I go home to Malaysia or she goes home to Algeria, she may say to her friend, it's been a while since we've had something to drink. What she means is that I'm thirsty. Okay? So her friend will say, let's go out and get something to drink. And she will say, no, please don't bother. Okay? What she means really is, if you ask me again, I'll say yes. Okay? So in the East, it's fine, because they recognize that pattern. But in the West, someone from Asia doing like this to a Western person, they don't understand. Okay? My wife is Dutch. And when in the UK, when we say, let me think about this, what does it mean? No, exactly. So yeah, so in the UK, when my wife said to me, can you do this thing? And I'll say, let me think about this. What I mean is no. But to the Dutch and the German, they think you're going to think about this and then come back with a decision. So that's an example of mitigated speech, yeah. Yeah.
I just wanted to add something. That the best example that I give is from our culture. आप किसी के घर जाते हैं, when you go to somebody's house, तो वो आपसे पूछते हैं चाय पिएंगे? नहीं मैं पी के आया हूँ. It's okay, I don't want tea. So, but still, they will bring in a trolley with kebabs and sandwiches and all that. नहीं, it's okay, मैं खा के आया हूँ, पी के आया हूँ. No, I'm not having it. So what happens with that is that they will insist 2-3 times, and then ultimately you will have it. When I went to UK, I went to somebody's house, and they did that. And I was really hungry, and I was expecting they will bring in. So they brought it, and that lady took it back. Well, I said no, because I was expecting she will push it 2-3 times. She never did that. So I think that that's a very good example of our culture, that if you go to somebody's house, you will never start eating straight away. You would expect the host will say 2-3 times.
Thank you, Osim, for sharing. So now we're going to watch a video. So this is Wasim Lodi when he was a registrar. He was covering labor ward, and he called his consultant because he had a patient who was in labor and she was having slow progress. So he called her to update her and to tell her his plans. Let's just watch the video and then we'll come back to it. Yeah, video.
I am covering Asaha B, but I'm also doing my clinic at the same time. What's the problem?
I would like to do a C-section on a lady who has been pushing for 90 minutes.
What are the findings? Is the head engaged?
Yes, she is fully dilated, and abdominally it feels 1/5 palpable, and it feels like OT, and I think the head is just above spines with lots of caput and molding.
Can you do a forceps?
Yeah, I can try forceps, but I'm not sure if it will come.
Is it a big baby?
No, just about average size.
Okay, carry on. I'll be around if you need me.
Do you want me to do a forceps? Should I take her to theatre and do it over there, or you want me to do it in the room?
Yes, do the forceps, whatever you think or wherever you think is best. I have to go now. It's a very big clinic. Bye.
Okay, so what was Wasim trying to tell his consultant? Sorry? Okay, so he wanted to, did you want to inform her, or was he trying to get advice from his consultant? So you feel that, okay, what does she need? What does this patient need? She needs cesarean, isn't it? Do we agree that the finding of Wasim, we wanted to do cesarean? So let's just see what he was trying to do. If we look at degrees of mitigations, so when we want something to happen, we say, do it. Yeah? And then if we're not sure, like you don't want to impose it on the person, you would say, let's just do the C-section and see if the person agree with you. And then, again, another degree is like you're not sure. You think, I wonder if we should go for cesarean. So you want the other person to say, yes, let's just go. And then the hint is giving this long explanation. So where was Wasim in this? What was he trying to do? He was giving her...
I think it was somewhere here.
Between query
Yes.
and hint, more towards hint. He was giving her all the information to say, this patient needs to have cesarean section. But he didn't say... Wasim was planning to inform his consultant that this patient needs a section and I'm going to take her for cesarean. But it took a long time to reach that point. Next.
Okay. So I think the point here really is that what pilots teach us is that you mustn't hint and hope. Okay? Hint and hope basically means you're hinting, hoping the other person will read your mind. So what you need to do really is either one command, which might be a bit aggressive, or suggestion. Okay? So that we share the same mental model. Okay. So this is quite interesting. This is an article from about 20 years ago where psychologists asked the aviation people, okay? And then he asked also surgical trainees, should you challenge your boss? Yeah? So among the aviation people, they say, of course you should, normal. Yeah, but for the surgeons, very rarely, you shouldn't challenge the boss. And it's still the same now. Many people don't like challenging because it's confrontational. Whereas in aviation, it's normal to share information and if something's wrong, to actually raise the issue. Yes?
Whether the lady, because he was more towards the cesarean section, but the lady was more in favor of forceps. So why the proper thing was not clearly communicated to the lady, because this could have again led to the wrong management.
Okay. So the question...
secondly, what your topic is that why you can't question. So Wasim should have questioned the lady that it's more, what he needs is a cesarean section rather than a forceps delivery.
Okay, so the question basically is that why wasn't it more direct in the approach, okay? And why didn't you question the consultant? That was a video made deliberately to show a bad mitigation, where you're just hinting and hoping. Perhaps you should do a new video, more the command thing, and how to do it properly.
And I think the RCOG has produced a nice tool, the next
so we will, that's just a video advising, showing the different types of mitigation.
So we discussed this earlier in my first talk, and this is a tool developed by Each Baby Counts, and how to escalate, mainly, okay? Can you just go to, so they developed 2 ways of escalating or talking to the consultant or your boss. So if you want to, like you're on call, you want to call your consultant, you need to clarify right from the beginning what you want from your consultant. So if you want an advice, you would go and you would start by saying, I'm asking you for advice. If you want to inform your consultant about something that you're going to do, you just go straight and say, I am informing you that I'm going to take patients for cesarean section. Now, if you want your consultant to come and do something during your shift, you need to be clear on what you're asking, and you need to go and say, I need you to do. This is very easy for us to say, but as consultants, we need to empower our junior doctors to be able to talk with the consultant like that. And that document is on RCOG, free access. I would advise you to have a look at it. Very interesting way of communicating and holding a conversation when you want to escalate. You can do it, like it can be done in reverse. Like, as a consultant, if you get a call from a junior doctor and you're not clear about what they want from you, you can ask them, are you asking me to advise you how you're going to manage this patient, or are you informing me that you're going to take the patient for cesarean? And one question that, as junior doctors, I remember, I used to love it when the consultant says, okay, I'm coming to do it, or do you want me to come and do? Because I couldn't say, this is very difficult for me, can you come and help me? So as senior people, if we empower our junior to speak up, if we want to put it that way, you would say, do you want me to do specific things? And what Wasim didn't do is that he didn't say, I'm informing you that this patient needs cesarean and we're going to take her.
Yeah, I think also our trainees in the UK are much more used to the system. They sort of, the communication is actually stronger, and they know what to expect, etc. Okay. So how would you challenge your consultant nowadays? So how do you share information? You think he's doing something wrong, about to do the wrong thing. How would you stop the consultant? Or what do you say to them? Sorry? Very good, very good. Okay, what else do you say? What sort of things? Because what we find really is that a lot of trainees, particularly from Africa and also from Asia, they find that they want to speak up, but they don't know the tools. Okay?
So we have techniques on how to speak up. So the PACE technique is good, and there is a CAS technique. So if Mr. Young is going to operate on the right ovary, and I can see him starting operating, removing the left ovary, I can probe him and say, oh, I thought we were operating on the right side. And then if he's not listening, I say, okay, we should be removing the right ovary. Still, he's focused on what he's doing and he's not listening. I would push it a little bit and say, I'm not happy, you're removing the wrong side. And of course, we reach the emergency status where you have to physically stop that person from doing something wrong that is going to harm the patient, okay?
So this is what you meant, I think, when you said, yeah. So a lot of our trainees use the CUS technique. This is very popular among pediatricians. And they say, I'm concerned. So these are trigger words. All the consultants will recognize this. I'm concerned, you're doing something wrong. I'm very uncomfortable. So when someone says to you, I'm very uncomfortable, in the UK, it means you're doing something wrong. So please stop. Okay? Or this is serious and this is unsafe. You will definitely stop. Okay. So this is an interesting question. Do you... One of the big issues in the UK really is that should you be calling your consultants by the first name? Because they think if you call by consultants by the first name, you create a very shallow authority gradient. What are your thoughts? Sorry? You called your consultant by the first name? No, I meant without a doctor, just calling first name. No. 4 minutes, okay. Fine. Again, there are cultural differences. For example, in the WHO checklist, we quite often call each other by the first name. Pilots call each other by the first name, okay? And it's thought that it actually reduces errors. So this is just a bit cheeky. Do you actually get a more shallow authority gradient if your junior doctor calls you and asks, do you come and do the ward round with me? Now, on paper, this sounds very interesting, but patients don't like it. Yeah? In the West, most patients don't like the junior calling you by the first name. Why do you think that is the case? Partly respect, but partly because they don't know who the consultant is. Yeah, so they don't know who's accountable. So if you call each other by the first name, the patient won't know who the senior person is. All right? Okay, so we'll go through that.
Okay, so how can we help junior doctors and empower them to speak up? One thing is to include the team in your decision making, especially like a good example when you do a ward round and you have a team of midwives with you, students and registrar and SHO. You know what you need to do for the patient, but you want to hear it from the team and you want to include them. So something like, what are your thoughts on the progress of this patient? You're giving them a space to give their opinion. Or when you finish and everything is decided, you can turn and say, is there anything anybody wants to add to the management? So these are just examples of how we can empower our junior doctors to speak up.
Okay. There's also an authority gradient between patients and doctors. Many patients will not speak up because they are frightened. Okay. So we probably need to end a little bit quickly. So one of the important things really is that you need to have psychological safety. So psychological safety is quite big in the UK, where you need to be empowered and you feel safe about challenging or about speaking up. Because by doing that, you then are more ready to actually admit your mistakes, and then you learn much better. Okay. Also, there's the concept of just culture. Okay, so with many organizations, British Airways, for example, they feel that it's very just, someone is accountable. They've never sacked any pilots, they tell me, okay? They may have gone for retraining, they may be reprimanded, but there's no sacking. On the NHS, there's also a just culture platform. There's a big difference between just culture and no blame culture. Many organizations will say that we have no blame culture. That means you don't blame anyone. But really, what you mean really is that you need to have a just culture where someone accountable has to be responsible. Okay. Okay. So the take-home points are, you should create a shallow authority gradient work environment so that the most junior medical student can actually speak up. And then the second part really is that the senior clinician needs to be actively listening. There's no point giving all the tools for the juniors to escalate if the senior person doesn't actually listen. Thank you very much. Thank you. Fine, thanks. Okay. Do you want to go first? Maybe you should go first.
Thank you so much for such an insightful talk. So due to time constraints, we are skipping the question and answer session for now. We will take the questions at the end of second session. So now we are moving towards our second session, which is on PPH management. Dr. Wai Yong is going to give us a presentation on reducing risk of PPH, role of technical and non-technical skills, and peripartum hysterectomy.
Okay. Yeah, fine, that's fine. So, so thank you. Because of a shortage of time, we'll proceed on to carry on the same theme. So human factors in the massive obstetric hemorrhage. So these are just some of the workshops we've done through different countries. So one really is here is in Nepal, in Spain, and then in Athens, and so forth. Okay. So now we're focusing quite a lot on technical skills. So this afternoon, after lunch, you'll be doing compression sutures, packing, Bakri balloon, and those are all different elements of technical skills, how to do a procedure. But what we find really is that it's just as important about the non-technical skills, so human factors. And we cover similar things as what my previous colleagues have discussed about. So we're talking about situational awareness, loss of time perception, decision-making, teamwork, communication, and ergonomics. And these are all things that are relevant, in particular, to MOH. Okay. So Prof. Arul used to give this talk a lot. I'm sure he's visited this Pakistan. And this is one of his slides, too little, too late. Quite often when you look at maternal death and serious morbidity from PPH, it's usually too little, too late. And if you look at the maternal mortality reports in the UK, same, too little, too late, and it's always the same. Okay? So this again is Prof. Arul's slide, his famous golden hour. In other words, the first hour, if you don't get everything right, people will die. The morbidity and mortality goes down the longer it takes to control the MOH. Okay? And when you look at all the reports, they're the same. Okay? They're mainly emergencies. There's lack of teamwork. There's poor staff skill mix. And you don't escalate. All the things you covered before. Okay? And what's interesting really is that aeroplanes also crash. And when you look at why they crash, very similar things. Loss of helicopter view, unclear communication, a lot of mitigated speech, yeah, where there's no command, there's just hint and hope, and then people not sure what the responsibilities are. Okay, so what's changed in the past few years really is that with the Embrace report, there's now a section highlighting the importance of human factors. It's something that's quite new, okay? And in particular, they always stress on situational awareness or the helicopter view. So it's something that we need to touch on, okay? We again wrote an article on the helicopter view a few years ago, and I encourage you to read that. So essentially, all of us have got a bucket containing how much we can work. Okay? So when the bucket overflows, we can't handle our workload anymore. Okay, we switch off.
The playing card.
Oh. Now, I want to do a little test for you. I want you to count the number of red cards on this video. Do you want to play that?
The playing cards are going to be dealt from the top of the deck onto the table. How many red cards are dealt? If you said 15, congratulations. But did you see the secret message on the back of the cards?
Well, did you see the message at the back of the cards? How many of you didn't see the message at the back of the card? There's actually a message. So what you've done really is you've target fixated on counting. That's normal. That's what I asked you to do. But you've lost the helicopter view because there's actually, if you see it again, take a step back and do a helicopter view, okay? There's actually a message at the end of
the playing cards are going to be dealt from the top of the deck onto the table. How many red cards are dealt?
Can you see that? Yeah. So what happens really is that in a PPH, if I get called in or Wasim gets called in or Professor Nazli gets called in, your job really is to go and stop the bleeding. So you go in, you will try to ligate the uterine artery or do a compression suture. You will be fixated. You'll be tunnel vision. You'll be counting the red cards. So you will lose track. It's normal. You will lose track of the helicopter view. You will lose track of the blood loss. You lose track of time. Okay? And you lose your hearing. That's normal. Okay? So, and pilots and ourselves are quite often are aware of these things. So we need to put in plans, strategies to compensate for this loss of situational awareness. Okay? So for situational awareness, a simple mnemonic is NUTA, N-U-T-A. See that? So level 1 means you notice, N. U is understanding. T, A is think ahead. Okay? So, NUTA. So what it means really is that, for example, you're assisting in a C-section, she's bleeding, and then you notice that the more she bleeds, the more you put in stitches, the more she bleeds. Okay? So that's your noticing. Understanding basically means she's probably developing DIC. Okay? So if you're very junior and you only notice at level 1, you might be putting in more stitches. Okay? So the experienced person will say, look, she's DIC. Don't put in any more stitches. Call for help. Yes, that's an example of DIC, situational awareness. And so when I get called in for stopping MOH, what I say to my team really, is that I'll be focused. I'll be fixated. I will lose the helicopter view. Can you please keep an eye on the time? Every 10 minutes, let me know. Can you, for example, look at the amount of blood loss? Every 500 mils, let me know, because I won't be able to keep an eye on that. Okay? And then later on, as a team, we need to develop bottom lines. Bottom lines means you need to warn me when we need to do a hysterectomy. Okay? So that's situational awareness. getting very, very close to decision making. All right, and I'll talk about that a bit later on. So this is an RCOG report, basically saying that you need to keep situational awareness. Someone needs to keep an eye on it, because it's very easy to actually become very fixated, and sometimes it's normal to become fixated. Okay. Okay. So pilots also like this threat and error management, they call this. Pilots are very risk averse. We are not so risk averse, but pilots are. So what pilots say really is that if you see danger coming when you're flying, big storm coming, you avoid it. Yeah, you go away from it. If you can't avoid it, you have to go there, then you trap it. If you can't trap it, then you mitigate it. Mitigate means reduce any errors. Okay? All right? So same thing, threat error management. Avoid, trap, and mitigate. Let me give you an example. I've been driving for 40 odd years, and I've had one major crash. That there, okay? Happened about 4 years ago. A French truck crashed into me. All right? And it's very interesting because, basically, I was in this lane near my hospital, and the truck was in this lane. Yeah? So I was turning right, and the French truck driver didn't know the rules, so he also turned right and crashed into me. Okay? So now, if I sort of reflect, the threat and error management means if I see a big truck in front of me, I don't go near there. I avoid it. Okay? If I can't avoid it and I have to go there, then I trap and mitigate. I have to be very careful. I turn off my radio, turn off any songs so that I'm not distracted, and then I keep very close eyes so that if they turn mistakenly, I can actually react. A PPH example. We used to be an accretor center, but we've been relocated, so now we no longer do accretors. So if you hear that a center accretor patient is bleeding, okay, if you apply the concept, avoid. First thing means don't come to my hospital because I haven't got all the equipment. No IR, okay? Avoid, send somewhere else. Yeah? But if she's contracting and bleeding a lot, and they are bringing to your hospital, then you have to trap it and mitigate it. You have to call in your senior consultants. You have to do it in the daytime hours. You may need to inform the urologists or the vascular surgeons. Okay, so avoid, trap, and mitigate. Okay, so next really is decision making. How many types of decision making do you know of? Well, first of all, are you good at decision making? You're all doctors. Are you good at decision making? Yes, okay. How many types of decision makings are you aware of? So a lot of people say there are two types. Okay, so that's the type 1, intuitive, and type 2, analytical. Okay, I'll give you an example. Can you read the next slide? Oops, sorry. Oops. Can you read that? Okay. So most of you will say the cat. Okay, that's type 1. That means you recognize it from your experience and you say it's the cat. But if you ask a 3-year-old to read it, they will say THECHT. Okay? So your type 1 decision making is fast, quite often lazy because you take shortcuts, okay? But it's very quick. Your type 2 or analytical is very slow. Okay, it takes time. And the difference really is that if you need quick decisions, you do type 1, and you need slow decisions, more careful, type 2. But nowadays, we have a type 3, which is basically rule-based. Okay? Example, when I was training, we didn't have 3 pulls. We didn't have the rules. So some people pull 5 times, some people pull once, and it's all judgment. Okay? And then sometimes people make the wrong decision. So now they put in a rule-based decision-making, which means you don't have to think very much, because in that emergency situation, you haven't got much thinking time. Yeah, you haven't got much RAM, so you just do 3 pulls. And you establish what we call a bottom line. Okay, how many pulls? Okay, So another example about decision making is bias. Yeah. So Monday morning, Wasim goes to labor ward. He sees a woman with a tense abdomen, 28 weeks APH. What he mustn't say is it's an abruption. Why is that? Sorry? Sorry? Okay, so what we try not to do is give a diagnosis. So what you mustn't say really is an abruption because of what we call the halo effect, anchoring, and confirmation bias. That means when he goes in, he's a senior person, so they all think, oh, he must be right. Okay, so I don't need to think anymore. He must be right, so it must be an abruption. Okay, so they start developing other thoughts. So what we advise people do really is that he goes in and he says, this lady's got APH, what should we do? What do you think it could be? Yeah, but in the back of his mind, he already is thinking it's an abruption. So then he sort of canvasses for your opinion, and then he sees what you think. Okay. So one of the things that one of the tools that we try to avoid really is something called analysis paralysis. Yeah. So again, pilots use this because some pilots, to make a decision to land, they have to have certain conditions. So some pilots, they can't decide. So they instead of landing, they do a fly around, and then they do a fly around again. So they call it analysis paralysis. That means they think so much, they can't make a decision. So what this guy says, he's one of the presidents of the United States really, is the best thing to do is to make the right decision. The next best thing is to make the wrong decision, and the worst thing is to make no decision. So in PPH, you have to make a decision. Okay. This just shows how difficult it can be to estimate blood loss. Okay, there are a lot of variations, particularly the best judge are basically the registrars, the most accurate at visual estimation. Okay, and small volumes is very, very difficult to judge. Okay, so this is actually from the Embrace report about how people miss cumulative blood loss. So in other words, this woman loses a little bit, loses a little bit, loses a little bit, and then overall you lose track. Okay? So that is called change blindness. Yeah? So what's this here? Scanning. Okay, yesterday we came through Lahore and they scanned this. So people who scan also find it very difficult to detect small changes. Okay? And so what they do really is every so often they basically change the scanners so that they have fresh eyes. And this slide basically is to show that it doesn't matter how much you lose, it's how much you weigh. Yeah? So for example, if I get called when I go home and the registrar says she's lost 2 liters, my question will be, what's her weight? Because 2 liters, 2 liters to a small woman weighing 50 kilograms can be half her volume, and it's very serious. 2 liters to a very big woman, sometimes our BMI are 40, 50, may not mean a lot. Okay? And sometimes it's actually missed if you just look at the estimated blood loss. Okay? So this is about S-bar. So important in PPH is to anticipate it. And here we're doing a briefing in a placenta creta. Okay? So it's quite important that we share the same mental model to do a proper checklist, and if there's, to encourage people to actually speak up if they see anything wrong. So the reasons we do briefing are basically twofolds. One really is to share the same mental model so that we all sharing the same thing, and then to establish bottom lines. So in an creta, for example, what we say really is that if she hits 4 liters, we need to bail out. You need to tell me. Yeah, because quite often people don't discuss those things, and then when it becomes very dangerous, they haven't got time to discuss that. Okay. So that's leadership and teamwork. So with our MOH thing, we feel that the new thing in the UK really is situational leadership. Yeah, that means the leader doesn't stay the same. Sometimes it changes. And sometimes we think the most senior person should be the leader, but that's not always the best thing. All right? It's the person who can take a step back and see the helicopter view, who should actually lead in MOH. Okay. Now, so this is basically, let me brief you. This is basically placenta creta, all right, and placenta previa. And we're going to be doing a classical cesarean section here. I want you to tell me who is leading the operation. There's a person in green gloves and the person in white gloves. Okay, just look at it carefully and see what you think. Okay, video please. So that woman actually wanted a conservative treatment of placenta creta. So she wanted her placenta left inside. She doesn't want a hysterectomy. Okay. So in that incident, there were 3 consultant obstetricians, 2 consultant anesthetists, and a consultant interventional radiologist. Who was leading? Green gloves or white gloves? Why do you say that? Sorry? She was what? Okay, fine. All right, so we turn on the volume, but you can actually say that. So yeah, it's quite right. So green gloves was myself. The white gloves was one of the new consultants. And then there's Dr. Lodi was actually videoing it because we thought it would be quite interesting one to video. This was a nice bit. We took out the baby, clamped the cord, left the placenta in and closed up. And she was good. And then suddenly she started bleeding. She lost 15 liters of blood. And what he didn't video really was that it was pandemonium. We also lost our situational awareness. Everybody was just rushing around. And then I couldn't lead because I was so stuck doing the target fixations, trying to stop the bleeding. And he was basically leading. So what it illustrates really is that sometimes the leadership changes because he had enough experience. He was doing the filming. He was doing the helicopter view. He was able to organize blood, call the ITU people, coordinate with pediatricians, and we just focus on stopping the bleeding. So we weren't leading. So it can rotate with the leadership. Okay, this is just about ergonomics, having a PPH trolley. This is actually interesting. These are our last few slides. Recently, we looked at the maternal death in Jehovah's Witnesses in the UK. Okay, Jehovah's Witnesses are probably quite rare in this country, but in the UK there are quite a lot of them, and they all refuse blood. So there's a high risk of maternal death. So since the maternal mortality report came out, there were 15 maternal deaths who are Jehovah's Witnesses who declined blood. Okay, and when we looked at it, it's actually quite common. Most of them lost situational awareness, and they made the decision to do a hysterectomy too late because they didn't establish the bottom line. So what we recommend really is that for Jehovah's Witnesses, once the hemoglobin drops down to about 8 to 9, you need to bail out and do a cesarean. You can't wait anymore. Okay. So these are. situational awareness, loss of time perception, how to overcome that, teamwork, decision-making, communication, ergonomics. And take-home points basically is you need to be aware of non-technical skills. It's crucial, and it complements whatever technical skills you have, okay, in MOH. Thank you very much. Thank you.
Thank you so much, Dr. Vai. That was a very informative presentation. Now I'm going to invite Dr. Sheherazad Rabi for her next talk on pseudoaneurysms and PPH.
Just a quick presentation on pseudoaneurysm. Let's just wait for... Okay, so we're talking here about pseudoaneurysm and postpartum hemorrhage. It's not working. Yeah, it's working. So just a quick definition. So for pseudoaneurysm, it's an injury to the arterial wall. And then there is a formation of hematoma on the outside wall. There isn't the true, like the three true layers of the arterial wall. Like compared to a true aneurysm where there is a bulge within the artery. It is rare, but serious complication and serious cause for PPH. And usually it follows a traumatic delivery. We see it more with complicated cesarean section, mainly when there is an angle extension during cesarean. So the patient would present with a secondary PPH, like more than 24 hours, but typically it takes about 2 weeks to reveal itself, and it can take up to 3 months. So there were like case reports of a patient who had cesarean section, and 3 months later she presented with recurrent bleeding. So the patient will be majority of cases, she would be stable with a lot of bleeding, recurrent bleeding. Pain is there, but the majority of cases, they are painless. And in extreme cases where the patient has lost quite a lot of blood, she will present in shock. Of course, the gold standard investigation is the CT angio, but we do, the first line is ultrasound, pelvic ultrasound, because we know that secondary PPH is related more to endometritis or retained product. So we shouldn't just jump into conclusion that it could be pseudoaneurysm and miss the most obvious ones. But when we do pelvic ultrasound and we put the color Doppler, there is a typical sign of turbulent forward and backward flow. Like the flow is in different directions. It's called the yin-yang sign, but if you look at it, it looks like the Pepsi sign. So in the literature, you will find either yin-yang or the Pepsi sign. As I said, the gold standard is CT angiogram. So this is typical ultrasound sign. And we can probably skip the video. Is the video playing? Hello? Can we play the video? If we just for a little while. Just to show you how it shows on ultrasound. So around that anechoic structure, so the big anechoic structure in the middle is the pseudoaneurysm, surrounded by uterine arteries. And then if you put the color Dopplers, you will see, so these are the uterine arteries. And then if you push a little bit, you will see that sign that was in the previous picture. Okay, we can move to the next slide. You can stop the video. Okay, so CT scan, it will show you the pseudoaneurysm and the connection. In that picture, we can see, where is that? Yeah, so that the connection between the fundal, like artery, and the pseudoaneurysm. So this is good in terms of diagnosis and treatment as well, because if we identify the pseudoaneurysm, so the next step would be to do uterine artery embolization before we reach the point of doing hysterectomy. This is the gold standard treatment, but if the patient is really unstable, then sometimes they end up with hysterectomy. Nowadays, people treat hysteroscopically, but we don't have really time to go through that. This is just a quick case presentation. So a 28-year-old lady who had 2 previous normal deliveries and then ended up with emergency cesarean with minimal blood loss, but she had a uterine angle extension. Recovery was uneventful, and she was discharged on day 2. But 2 weeks later, she was admitted with painless, brisk vaginal bleeding. She was completely stable at the beginning, but with recurrent bleeding and one heavy bleed, she had 3 liters blood loss, and her HB dropped from 93 to 65. So she was resuscitated and given blood transfusion. On ultrasound, we can see the typical sign of pseudoaneurysm, and she had embolization and recovered. The most important thing is to repeat another ultrasound and make sure that it's been treated. So usually 6 weeks later, you should rescan your patient to make sure that the treatment has worked. So it is rare, but it's a serious complication. But please don't start looking for pseudoaneurysm when a patient presents with postpartum hemorrhage, because the most common reasons are endometritis and retained product, which are both very, very easy to treat and manage. This is my talk on pseudoaneurysm. I just want to show you one thing about Bakri balloon, and it will be part of this workshop this afternoon. But I would like to show you. Wasim, can you just ask him to put the Bakri tamponade, please? Sorry, that was a quick. You don't have the Bakri? There's nothing? We can show it in the, yeah, okay, no problem at all. Okay, sorry about the rush in this presentation, and we can take questions if you want. Yeah, okay, thank you.
Thank you so much, Dr. Scheherazade.